Hello and welcome. Do you want to successfully complete the D583 OA exam? Then you are in the right place. Our website has free questions and answers for the D583 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from early psychologists, developmental theories, cognitive neurobiology, visual imagery, language, and memory. So let's get started.
Question 1. A community health nurse plans a workplace flu vaccination clinic for an accounting firm during October before influenza season begins in the local hospital service area. The clinic targets healthy employees with no current symptoms. Which level of prevention does this initiative best represent? Your options are A. Tertiary prevention through symptom management, B. Quaternary prevention through reducing overtreatment, C. Primary prevention through risk reduction, D. Secondary prevention through early detection. Which one is it? Pause the video if you need more time. The correct answer is C. Primary prevention through risk reduction. C is correct because primary prevention stops disease before it starts by reducing risk factors or building resistance. Vaccination is the textbook example because the immune system gains protection before any exposure occurs in employees. A is wrong because tertiary prevention manages complications in patients with established disease, like cardiac rehab after heart attack. The flu clinic targets healthy adults without disease, so this answer mismatches the intervention timing entirely. B is wrong because quaternary prevention protects patients from harm caused by excessive medical care, like discouraging unnecessary antibiotics. A vaccine clinic actively adds care rather than reducing it, so this category does not apply here. D is wrong because secondary prevention detects existing disease early through screening, like mammograms or blood pressure checks. Vaccinating people who have no symptoms is not screening and happens before, not during, an active infection. Public health prevention isn't one idea. It's a structured timeline that follows a population from fully well all the way through established disease and treatment. Each stage has its own target, its own tools, and its own goal. Leavell and Clark formalized this continuum in 1953 after observing that some interventions saved millions of lives while others barely moved the needle. The insight was that blocking onset, catching early disease, and managing established disease are three entirely different enterprises, kids, each with different teams, price tags, and populations. Primary prevention works through two main pathways: reducing exposure to risk, think fluoridated water, lead paint removal, and seatbelt laws, and building individual or population resistance, which is exactly what vaccination does. Both pathways share one defining feature: the intervention lands before any biological damage has begun. On exam questions, distractors will name the wrong prevention level to pull you off course. Lock onto two signals: the patient's current health state and what the intervention is actually doing. Match those two together and the correct prevention level answers itself almost every time. Question 2. A health system rolls out routine mammograms for women aged 40 to 74 through its primary care clinics. The program is designed to catch breast cancer at early stages when treatment outcomes are strongest. Which level of prevention does this screening program best represent? Your options are A. Secondary prevention through early detection, B. Primary prevention through risk reduction, C. Quaternary prevention through limiting interventions, D. Tertiary prevention through complication control. Take a second. Which answer would you pick? The correct answer is A. Secondary prevention through early detection. A is correct because secondary prevention identifies disease at early stages, before symptoms worsen, so prompt treatment can halt progression. Mammograms, pap smears, and colonoscopies are the canonical screening tools that define this prevention level. B is wrong because primary prevention prevents disease onset entirely through vaccination, lifestyle change, or seatbelt use. A mammogram does not stop cancer from forming, so it does not meet the timing requirement of primary prevention. C is wrong because quaternary prevention guards against overdiagnosis and unnecessary procedures. While mammogram overuse can spark this debate, the routine screening program itself is designed to find disease, not to limit care delivery. D is wrong because tertiary prevention helps patients with established disease manage complications, like physical therapy after a stroke. Mammography occurs before any breast cancer diagnosis, which places it earlier on the prevention continuum than tertiary. Secondary prevention targets people who feel completely well but may be carrying disease that hasn't produced symptoms yet. The core insight is simple. Finding disease earlier changes outcomes in ways that finding it later simply cannot. Effective screening requires all three elements working together. A sensitive test applied to a defined asymptomatic population, paired with a proven treatment pathway. Remove any one element and screening stops helping people and starts harming them, which is exactly why the US Preventive Services Task Force reviews proposed screens so carefully. The mechanism is a screen-treat cycle. A larger symptomatic population gets tested on schedule. Most test negative and return to routine care. A smaller fraction test positive. Move into diagnostic workup. And if disease is confirmed at an early treatable stage, curative treatment follows. The math works when the disease is serious enough and the test accurate enough to justify scanning everyone. Newcomers often confuse primary and secondary prevention because both act on people who appear healthy. The distinction is what the clinician is looking for. Primary prevention stops disease from beginning. Secondary prevention finds disease that has already begun but hasn't yet announced itself through symptoms. On exam questions, if the population has no symptoms and the intervention is a screening test, mammogram, colonoscopy, blood pressure check, newborn heel stick, the answer is secondary prevention. Screening finds what the patient cannot yet feel, and early detection is what makes the difference. Question 3. A patient who survived a left-sided cerebrovascular accident 6 weeks ago begins outpatient physical and speech therapy 3 days per week. The goal is restoring function and preventing further disability from the existing stroke. Which level of prevention does this rehabilitation program best illustrate? Your options are A. Quaternary prevention by limiting medical care. B. Tertiary prevention by reducing disease impact. C. Primary prevention by stopping new disease. D. Secondary prevention by detecting hidden illness. Before I reveal it, which one do you think is right? The correct answer is B. Tertiary prevention by reducing disease impact. B is correct because tertiary prevention manages complications and disability in patients who already have established disease. Stroke rehabilitation is the classic example because therapy aims to restore function and limit long-term consequences after the event. A is wrong because quaternary prevention reduces over-medicalization, like avoiding unnecessary imaging or duplicative procedures. Stroke rehabilitation is medically indicated and not designed to limit care delivery. So this category mismatches the patient scenario described. C is wrong because primary prevention stops disease before it occurs through actions like blood pressure control or smoking cessation. The patient already had the stroke, so the timing window for primary prevention has clearly passed. D is wrong because secondary prevention catches disease early through tools like cholesterol screening or blood glucose testing. The diagnosis here is already established and the patient is in the recovery phase, which sits past the screening window. Tertiary prevention begins only after a diagnosis is established. The disease has already caused some damage, and the clinical mission shifts entirely. from stopping the condition to limiting how much further it can take from the patient. Work at this level targets 3 linked outcomes: restoring lost function, preventing downstream complications and recurrence, and protecting quality of life over the long arc of the disease, not just the acute episode. The clearest way to see tertiary prevention is to separate it from treatment. A cardiologist who stents a blocked artery during a heart attack is treating an acute event. The 12-week cardiac rehab program that follows, teaching exercise, stress management, and behavior change, is tertiary prevention. One acts on the moment, the other acts on the months and years that follow. On the exam, these terms reliably flag tertiary prevention if the stem places the patient on the disease side of the line. Somerset, already diagnosed, and the intervention aims to restore function or prevent further decline. The answer is tertiary. Distractors will borrow language from primary or secondary prevention to create confusion. Remember, if the patient already has the disease and the care aims to restore function or hold back further damage, you are in tertiary territory. Rehab germ, dialysis chair, diabetes class, slow, specific, measurable work that lives entirely after the event earlier prevention levels try to stop. Question 4. A primary care physician reviews a patient request for an antibiotic prescription to treat a viral upper respiratory infection lasting 4 days. The physician explains why antibiotics will not help viral illness and recommends supportive care instead. Which prevention level does this clinical decision best represent? Your options are: A. Primary prevention by avoiding initial illness. B. Tertiary prevention by managing chronic complications. C. Secondary prevention through early symptom detection. D. Quaternary prevention by avoiding unnecessary care. What's your answer? Commit to one before I continue. The correct answer is D. Quaternary prevention by avoiding unnecessary care. D is correct because quaternary prevention protects patients from harm caused by excessive or unnecessary medical care. Avoiding antibiotics for viral illness prevents adverse effects and resistance, the textbook example of this protective prevention category. A is wrong because primary prevention prevents disease through interventions like vaccination or healthy lifestyle promotion. Declining an antibiotic for an existing viral infection does not stop disease onset, so this level does not match the scenario. B is wrong because tertiary prevention manages complications in patients with chronic established disease. The patient has an acute viral illness, not chronic disease, and the physician is not addressing complications of an existing condition. C is wrong because secondary prevention uses screening to detect disease before symptoms worsen. The patient already has symptoms, and the physician is not running diagnostic tests. So screening logic does not fit this clinical decision. Quaternary prevention is the newest and most counterintuitive of the 4 prevention levels. Unlike the others, its target isn't disease. It's the potential harm caused by medical care itself. Medical harm flows through 3 patterns. Overdiagnosis finds disease that would never have hurt the patient. Overtreatment applies interventions that exceed what's needed. And overtesting generates false alarms that trigger further invasive workup. Quaternary prevention interrupts all 3. The key inversion is the direction of harm. Primary, secondary, and tertiary prevention all protect patients from disease. Quaternary prevention protects patients from the clinical system, a reversal that catches newcomers off guard. On the exam, quaternary prevention signals include antibiotic stewardship, avoiding low-yield imaging, and shared decision-making conversations that end in declining intervention. The clinician is acting in the patient's best interest by withholding care, less medicine as the treatment itself. Question 5. A public health department launches a multi-component diabetes program. It offers community Zumba classes, free hemoglobin A1C screening at health fairs, an insulin titration clinic for diagnosed patients, and a shared decision-making tool to limit unneeded foot amputations. Which option correctly orders the prevention levels involved? Your options are A. Primary, secondary, tertiary, quaternary. B. Secondary, primary, quaternary, tertiary. C. Tertiary, quaternary, primary, secondary. D. Quaternary, tertiary, secondary, primary. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Primary, secondary, tertiary, quaternary. A is correct because the 4 components map cleanly onto the prevention continuum in order. Exercise classes prevent onset. A1C screening detects early disease. Insulin clinics manage diagnosed disease. And shared decision-making prevents unnecessary surgical harm. B is wrong because reordering the components disrupts the chronological logic of prevention. Screening is not primary. Exercise is not secondary. And a shared decision-making tool sits in quaternary, not tertiary, which breaks the conceptual sequence. C is wrong because starting with tertiary inverts the standard temporal flow of prevention. The full continuum moves from preventing onset to detecting early disease to managing established disease, then finally to limiting harm from over-treatment. D is wrong because reversing the continuum entirely puts over-medicalization protection before disease prevention itself. The standard ordering tracks the patient timeline from healthy through diagnosed through complicated, which this answer fails to follow correctly. The prevention continuum isn't just a list. It's a timeline that mirrors how disease actually moves through a person and a population. Understanding the logic behind the ordering is what makes exam questions straightforward. A person moves forward along this timeline, never backward. Healthy becomes at risk becomes a symptomatic disease, and so on. Each prevention level exists to serve the population sitting at exactly that point on the journey. The levels function as a stepwise safety net. Primary stops some disease from starting, but not all. Secondary catches early disease that primary missed. Tertiary manages established disease that secondary didn't detect. And quaternary guards against the overtreatment that tertiary can sometimes generate. A riddle program touches all 4 levels at once because its population spans every disease stage simultaneously. On ordering questions, identify the patient state each intervention acts on, well, asymptomatic, diagnosed, or already treated, and the chronological sequence arranges itself automatically. The most common trap is confusing tertiary and quaternary. Insulin therapy for a diagnosed patient is tertiary. Avoiding an unneeded amputation through shared decision-making is quaternary. Read the patient state first, then place the intervention, and the order writes itself every time. Question 6. During the 1854 cholera outbreak in the Soho district of London, a physician mapped cases street by street and traced the source to a single contaminated water pump on Broad Street. Which historical figure performed this investigation and earned recognition for it? Your options are A. Edward Jenner, smallpox vaccine pioneer. B. Edwin Chadwick, sanitary report author. C. John Snow, father of modern epidemiology. D. Louis Pasteur, germ theory co-founder. Which would you go with? Lock it in before the reveal. The correct answer is C. John Snow, father of modern epidemiology. C is correct because John Snow conducted the Broad Street pump investigation in 1854, mapping cholera cases and identifying contaminated water as the source. This work earned him recognition as the father of modern epidemiology. A is wrong because Edward Jenner introduced smallpox vaccination in 1796 using cowpox material decades before the London cholera outbreak. He is foundational to immunization history, but did not perform the Broad Street pump investigation in Soho. B is wrong because Edwin Chadwick authored the 1842 sanitary report linking poverty to disease and helped pass the Public Health Act of 1848. He shaped sanitation policy but did not lead the Broad Street pump investigation. D is wrong because Louis Pasteur and Robert Koch established germ theory in the 1860s through experiments showing microorganisms cause disease. Their work transformed medicine but came after the Broad Street investigation and did not involve cholera mapping. Before epidemiology existed as a science, disease was blamed on bad air. One physician in London changed everything by doing something radically simple. He drew a map. The dominant theory of Snow's era held that cholera and plague arose from noxious vapors in the environment. This miasma theory was deeply entrenched and, as Snow would demonstrate, completely wrong. Snow walked Soho house by house, recording every death and plotting it on a street map. The cases clustered unmistakably around a single public pump on Broad Street. People who drank from it died. People who drew water elsewhere, even across the same street, did not. Snow's workflow was deceptively simple. Map where cases occur, identify the contaminated source, and eliminate access to it. Convincing authorities to remove the Broad Street pump handle stopped the outbreak, the first targeted epidemiologic intervention in history. If a question describes case mapping, a contaminated water source, and a pump handle removal, the answer is John Snow. Jenner preceded him and Pasteur followed, but Snow alone invented outbreak investigation as we practice it today. Question 7. In 1377, a port city established the first formal quarantine station, requiring arriving ships to wait offshore for 40 days before crew or cargo could disembark. This intervention emerged in response to recurring bubonic plague outbreaks in Europe. Which city implemented this measure? Your options are A. Florence, Italy during the Renaissance, B. Venice, Italy during the Middle Ages, C. London, England during the Enlightenment, D. Paris, France during the Industrial Revolution. Don't overthink it. Which one feels right? The correct answer is B. Venice, Italy during the Middle Ages. B is correct because Venice established the first quarantine station in 1377, requiring 40-day ship waits, which is where the word quarantine originates. This Middle Ages response to bubonic plague is a foundational moment in public health practice. It is wrong because Florence created early public health boards during the Renaissance 15th century to manage sanitation and outbreaks. The first formal quarantine station predates that work and arose in a different Italian city-state during the Middle Ages. C is wrong because London became central to public health much later, with the Public Health Act of 1848 and the cholera investigations of John Snow. The Enlightenment era contributed statistical methods but not the original quarantine innovation. D is wrong because Paris developed sanitation infrastructure during the Industrial Revolution and Victorian era, while French public health advanced significantly in that period. The original 40-day quarantine station emerged centuries earlier in a Mediterranean trading city. Quarantine wasn't invented by modern medicine, it was invented by medieval trade. The underlying problem was simple. Ships moved disease faster than governments could react, and by the time a vessel docked, the pathogen was already in the city. Venice was the first jurisdiction to formalize this buffer. In 1377, 40 giorni, 40 days, arriving ships were held offshore. Critically, this was not a recommendation. Ships were seized, captains imprisoned. Legal enforcement is what turned public health advice into public health policy. The mechanism works because every infectious disease has a finite incubation period, a window where someone carries the pathogen but shows no symptoms. Hold exposed people through that window under isolation and the biology reveals itself. Venice didn't understand germ theory, but they observed this pattern empirically and built policy around it. From Ebola screening at modern airports to COVID isolation guidelines, The core logic is identical to what Venice codified 6 centuries ago. Hold the exposed long enough for the biology to declare itself. Match Venice, 376, and the 40-day ship hold, and any exam question on quarantine history becomes straightforward. Question 8. In 1796, an English physician inoculated a young boy with material taken from a dairymaid's cowpox lesion, then later exposed the boy to smallpox. The boy did not develop the disease, launching the science of vaccination. Which physician performed this procedure? Your options are A. Robert Koch, microbiology pioneer. B. Joseph Lister, antiseptic surgery founder. C. Louis Pasteur, fermentation researcher. D. Edward Jenner, smallpox vaccine inventor. Got a guess? Lock it in. The correct answer is D. Edward Jenner, smallpox vaccine inventor. D is correct because Edward Jenner performed the 1796 cowpox to smallpox inoculation that launched vaccination science. His work eventually led to the global smallpox eradication campaign and the disease being declared eradicated worldwide in 1980. A is wrong because Robert Koch worked decades later in the 1870s and 80s, isolating organisms responsible for tuberculosis and cholera. His postulates shaped germ theory but did not include the original smallpox vaccination experiment with cowpox material. B is wrong because Joseph Lister introduced antiseptic surgical practice in the late 19th century, dramatically reducing wound infections in operating rooms. He worked alongside germ theory pioneers but did not develop the smallpox vaccine using cowpox. C is wrong because Louis Pasteur developed pasteurization and the rabies vaccine in the 1800s, contributing major advances to germ theory. However, the original smallpox vaccine was developed about a century earlier by a different European physician entirely. The story of vaccination begins not in a laboratory but in the English countryside, with the simple observation that milkmaids rarely died of smallpox. Edward Jenner turned that folk wisdom into the founding experiment of modern immunology. Smallpox was the leading killer of European children, and the only prevention, variolation with live smallpox material, carried its own deadly risk. Jenner asked whether cowpox, a mild disease, could provide the same protection without that danger. Jenner took fluid from cowpox lesions on a milkmaid named Sarah Nelmes and scratched it into the arm of 8-year-old James Phipps. The boy recovered from a mild cowpox infection, and when later exposed to real smallpox material, he did not develop the disease. Though Jenner could not explain the mechanism, we now know cowpox and smallpox viruses share enough surface antigens that immunity to one provides cross-protection against the other. Every modern vaccine, from flu to COVID, exploits the same principle of teaching immune memory before real exposure. Jenner published his findings in 1798, naming the method after vaccinia, the Latin word for cowpox. That single paper from a rural English clinic is the direct ancestor of every vaccine ever developed, culminating in the global eradication of smallpox in 1980. Question 9. Throughout the 1860s and 1880s, 2 scientists conducted experiments demonstrating that microscopic organisms cause specific diseases, displacing the earlier belief that bad air or miasmas caused illness. This shift transformed sanitation, surgery, and public health practice forever. Which pair developed this foundational theory? Your options are A. John Snow and Edwin Chadwick partnership. B. Edward Jenner and Joseph Lister team. Sir Louis Pasteur and Robert Koch researchers. D. Hippocrates and Andreas Vesalius scholars. Which one is it? Pause the video if you need more time. The correct answer is C. Louis Pasteur and Robert Koch researchers. C is correct because Louis Pasteur and Robert Koch produced the experimental evidence proving microorganisms cause disease, with Joseph Lister contributing through antiseptic technique. Their work in the 1860s through 80s displaced miasma theory and reshaped medicine permanently. A is wrong because John Snow and Edwin Chadwick worked on cholera and sanitation policy in mid-19th century England, helping pass the Public Health Act. Their contribution was epidemiology and reform, not the laboratory science behind germ theory. B is wrong because Edward Jenner pioneered vaccination in 1796 and Joseph Lister introduced antiseptic surgery later. Both relied on germ theory eventually, but neither produced the original experimental evidence proving microorganisms cause specific diseases in humans. D is wrong because Hippocrates developed humoral theory in ancient Greece and Andreas Vesalius advanced anatomy during the Renaissance. Both shaped medical history, but neither produced the experimental microbiology that established germ theory in the 19th century. Germ theory transformed medicine by establishing that specific microorganisms cause specific diseases. Before this idea took hold, physicians blamed illness on humoral imbalance, miasmas, and bad air, frameworks that made disease prevention essentially impossible. The shift was profound in two directions at once. Disease causation became concrete and measurable, and that meant both prevention and treatment could be aimed at a specific biological target rather than a vague environmental condition. Pasteur demonstrated that living microorganisms drive fermentation and spoilage, directly challenging spontaneous generation. Koch then formalized causation with his postulates: find the organism in every case, isolate it, reproduce the disease in a healthy host, and recover the same organism again. Koch's postulates became the gold standard for causation claims for the next century. They were the first rigorous logical framework that forced researchers to prove, not merely observe, that a microorganism was responsible for a disease. Joseph Lister immediately applied Pasteur's insights to surgery, cutting post-operative infection mortality dramatically with carbolic acid sterilization. That single clinical change illustrated the entire promise of germ theory. Once causation is concrete, intervention becomes precise, and outcomes transform within a generation. Question 10. Around 460 to 370 before the Common Era, a Greek physician produced writings that linked health to balance among bodily fluids and emphasized lifestyle factors like diet, exercise, and sanitation. This period is commonly considered the starting point of public health practice. Which civilization? Your options are A. Ancient Greece during Hippocratic era, B. Ancient Egypt during the Nile dynasties, C. Medieval Europe during plague outbreaks, D. Renaissance Italy during anatomy studies. Take a second. Which answer would you pick? The correct answer is A. Ancient Greece during Hippocratic era. A is correct because ancient Greece during the Hippocratic era developed humoral theory and emphasized prevention through diet, exercise, and public bathing. These contributions place ancient Greece as the conventional starting point for organized public health practice in textbooks. B is wrong because ancient Egypt produced advanced medical practices and sanitation infrastructure, but its contributions are not labeled as the formal starting point of public health. Most public health timelines begin with the Hippocratic writings of Greek physicians. C is wrong because medieval Europe contributed quarantine practice and plague-era sanitation laws, but those measures came roughly 17 centuries after the conventional starting point. The Middle Ages built on, rather than originated, the public health tradition. D is wrong because Renaissance Italy produced public health boards and the printing press distribution of medical knowledge, but those advances came later. The customary starting point sits much earlier, with the writings of Greek physicians on humoral balance. Public health as an organized discipline didn't begin with germ theory or even quarantine. It traces back more than 2,000 years to ancient Greece, where physicians first developed a systematic framework for understanding and preventing disease. Hippocrates and his followers produced the Hippocratic corpus, introducing two ideas that remain central to modern public health. Disease arises from natural causes, and lifestyle factors like diet, exercise, and sanitation shape health far more powerfully than any single treatment. Humoral theory was biologically wrong, but structurally ahead of its time. It argued that health depended on balance among 4 bodily fluids. Modern physiology replaced those fluids with hormones, electrolytes, and immune components, but the core insight that disease reflects systemic imbalance survived completely intact. Beyond theory, ancient Greece contributed practical public health tools, systematic patient observation that prefigured epidemiology, public bathing and civic sanitation infrastructure, and early versions of isolating contagious patients, all before Rome's famous aqueducts and centuries before medieval quarantine. Every major development that followed, quarantine, germ theory, modern epidemiology, built on this ancient Greek foundation without replacing it. When an exam question asks where organized public health thinking began, ancient Greece and the Hippocratic writings are the answer. Question 11. A southern state operates its public health system through a single state agency that directly manages employees, sets policy, allocates funding, and runs all county health offices from the capital. Local input is limited to advisory committees with no decision authority. Which structural type does the state use? Your options are A. Decentralized public health structure, B. Mixed structure public health system, C. Shared public health structure, D. Centralized public health structure. Before I reveal it, which one do you think is right? The correct answer is D. Centralized public health structure. D is correct because centralized structures concentrate decision-making, coordination, and funding in a single overarching state authority that directs local public health activity. The scenario matches this definition exactly, with the state managing every operational detail uniformly. A is wrong because decentralized structures place decision-making and resource allocation at local levels, with counties or municipalities running their own public health agencies. The scenario describes the opposite arrangement, with all authority sitting at the state capital. B is wrong because mixed structure systems combine state-run and locally governed health departments within the same jurisdiction. The scenario describes uniform state control across all counties, which lacks the patchwork feature that defines mixed arrangements. C is wrong because shared public health structures distribute responsibility across state, local, and private partners through formal collaboration. The scenario describes a single state agency with no shared authority, which excludes the cooperative element of shared systems. Public health systems are built around a fundamental design question: where does decision-making authority actually sit? The answer defines how policy gets made, how staff get hired, and how funding flows across an entire state. States independently chose their structural model over a century ago. Centralized systems place authority at the state level. Decentralized systems push it to counties and cities, and mixed systems split responsibility between both. In a centralized structure, one state agency runs every local office as a direct branch. State-employed staff, state-controlled budgets, and state-set policy apply uniformly from the capital to every county simultaneously. Yes, Sam. As Florida's Department of Health demonstrates across all 67 counties. When a question describes policies set from the capital, staff hired into state civil service, and local officers with limited autonomy, that compound of signals points to a centralized structure. Centralization buys consistency. Every county follows the same protocol simultaneously. The predictable cost is reduced flexibility for local needs. One agency, one policy, every county. That is the defining logic of a centralized public health system. Question 12. A Midwestern state lets each county operate its own public health department with its own director, budget, and policy priorities. Counties hire their own staff and decide which programs to fund. The state offers technical guidance but does not direct operations. Which structural type does this represent? Your options are A. Centralized public health structure, B. Decentralized public health structure, C. Shared public health structure, D. Mixed structure public health system. What's your answer? Commit to one before I continue. The correct answer is B. Decentralized public health structure. B is correct because decentralized structures distribute decision-making, coordination, and resource allocation across local authorities with substantial autonomy. The scenario fits this pattern exactly, with each county running its own health department free from state operational direction. A is wrong because centralized structures concentrate authority in a single state agency that directs local activities uniformly. The scenario describes the opposite, with counties making independent decisions about programs and budgets, which is incompatible with central state control. C is wrong because shared structures involve formal collaboration between state, local, and private organizations through joint decision-making. The scenario describes counties acting independently rather than collaboratively with state and private partners, so the shared label does not fit. D is wrong because mixed structure systems contain both state-run and locally governed departments within the same jurisdiction. The scenario describes uniform local control across all counties, which lacks the hybrid character that defines mixed arrangements in practice. In a decentralized public health system, authority doesn't flow down from the state. It lives at the local level. Counties and municipalities run their own departments, set their own priorities, and answer to their own communities. Each county controls its own funding drawn from local taxes, hires staff into county civil service, and makes policy decisions through local boards and commissioners. The state offers guidance and technical support but does not direct day-to-day operations. Compare the two structures visually. In the centralized model, the state directs everything downward. In the decentralized model, counties operate independently and the state plays an advisory role, connected by coordination rather than command. The flexibility of decentralization is also its vulnerability. A county can act quickly and tailor programs to its population, but two neighboring counties may deliver very different levels of care, and during a multi-county outbreak, that inconsistency becomes a serious liability. Decentralized means local. If counties control their own budgets, staff, and decisions while the state only advises, that is the defining signal. The trait is responsiveness for consistency, the exact inverse of the centralized model. Question 13. A northeastern state contains 3 large urban county health departments operated locally with their own commissioners, alongside 15 smaller rural counties whose health departments are run directly by state employees from the capital. Funding flows from both state and county sources. Which structural type best fits? Your options are A. Decentralized public health structure, B. Centralized public health structure, C. Mixed structure public health system, D. Shared public health structure. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Mixed structure public health system. C is correct because mixed structure systems combine elements of both centralized and decentralized approaches, with some local departments state-run and others locally governed. The scenario matches this hybrid pattern, balancing state oversight with local flexibility across counties. A is wrong because decentralized structures put all decision-making at the local level uniformly across the jurisdiction. The scenario contains both state-run and locally run departments within the same state, which exceeds what a purely decentralized arrangement would describe. B is wrong because centralized structures keep all authority at the state level. The scenario shows 3 urban counties operating independently with their own commissioners, which contradicts the uniform state control that defines centralized systems in practice. D is wrong because shared structures emphasize collaboration between state, local, and private organizations through formal partnerships. The scenario does not describe joint decision-making with private partners, so the shared label misses the defining feature of that structural type. When we talk about mixed structure public health systems, we mean states where some counties operate under direct state control while others run their own independent local departments. This isn't a design flaw, it's the product of history. Urban counties that built strong public health infrastructure early, often before the state did, were able to retain their independence. Rural counties with smaller tax bases and less capacity were later absorbed into the state structure. New York City is the classic example, operating its own department entirely separate from the state agency. Mixed structures try to capture the best of both worlds. Urban counties keep the local flexibility their complex populations need. Rural counties receive state resources their tax bases can't generate alone, and the state retains enough authority to coordinate across all counties during emergencies. The trade-off is real administrative complexity. Funding mechanism, staffing arrangements, and policy authority all vary county by county. During a multi-jurisdictional outbreak, coordination depends on interagency agreements that can take years to negotiate, making the mixed model powerful in theory but demanding in practice. Question 14. A Western state coordinates public health work through formal partnerships among the state health department, county departments, hospital systems, federally qualified health centers, and a regional nonprofit foundation. All partners share funding decisions and strategic planning through a chartered governance body. Which structural type does this arrangement represent? Your options are A. Shared public health structure, B. Centralized public health structure, C. Mixed structure public health system, D. Decentralized public health structure. Which would you go with? Lock it in before the reveal. The correct answer is A. Shared public health structure. A is correct because shared structures distribute responsibility and authority across state, local, and private entities through collaborative decision-making and funding. The scenario fits exactly, with formal partnerships among state, local, hospital, clinic, and foundation partners participating jointly. B is wrong because centralized structures keep authority at a single overarching state level. The scenario describes formal partnerships, including private organizations like hospitals and a foundation, which contradicts the single authority feature that defines centralized systems in textbooks. C is wrong because mixed structure systems combine state-run and locally governed departments within one jurisdiction. The scenario does not focus on whether departments are state or county run, but rather on cross-sector partnership, including private entities. D is wrong because decentralized structures push decision-making to local government authorities with autonomy. The scenario describes joint decision-making among state, local, and private partners rather than autonomous local control, which misses the cooperative element entirely. When public health challenges exceed what any single agency can handle, formal cross-sector structures bring government, hospitals, foundations, and community organizations together to govern and act as one. The shared model deliberately combines state and local government with hospital networks, federally qualified health centers, non-profit foundations, and faith-based organizations, each contributing resources and sitting at the same governance table. A formal charter defines how these partners make decisions together, how funding crosses organizational boundaries, and how accountability is distributed when outcomes fall short, distinguishing shared structures from simple contracting or grant-making. Shared structures are distinct because private organizations hold genuine decision-making authority, not just service delivery roles. Hospitals reduce avoidable ED use, foundations advance philanthropic missions, and government extends its reach, creating aligned incentives that sustain the partnership. If a scenario describes hospitals, foundations, or other private entities sharing decision-making authority alongside government, that is the hallmark of a shared public health structure. Collaboration traded for slower, more negotiated but far more coordinated population-level action. Question 15. A new state public health director wants to ensure uniform vaccination policy and standardized data reporting across all 67 counties, while also maintaining tight central control over the agency budget. Which structural type would best support these specific operational goals for the new director's strategy? Your options are a decentralized public health structure, B, mixed structure public health system, C, shared public health structure, D, centralized public health structure. Don't overthink it. Which one feels right? The correct answer is D, centralized public health structure. D is correct because centralized structures concentrate decision-making, coordination, and resource allocation at a single state authority. The director's goals of uniform policy, standardized reporting, and central budget control align directly with what centralized arrangements deliver by design. A is wrong because decentralized structures grant counties autonomy over their own decisions and budgets, which produces inconsistency across regions. The director wants uniformity and central budget control, both of which a decentralized arrangement would actively undermine in practice. B is wrong because mixed structure systems balance state oversight with local flexibility, which means some counties keep autonomy. The director wants uniform policy across all counties, so a hybrid arrangement would not deliver the consistency the strategy specifically requires. C is wrong because shared structures rely on collaborative decision-making among state, local, and private partners. The director wants tight central budget control, which conflicts directly with the joint funding decisions that shared structures depend upon to function. Choosing a public health structure is a strategic decision, not a moral one. The right structure depends entirely on which goal your state most needs to achieve. No single structure delivers everything at once. Each structural type is engineered to deliver one primary goal reliably. Centralized structures maximize uniformity. Decentralized structures maximize local responsiveness. Mixed structures balance both. Shared structures unlock cross-sector partnerships with hospitals, foundations, and community organizations. Think of it as a direct lookup. Read the dominant priority in the question stem, then name the structure that delivers it. Trade-offs are unavoidable. Optimizing for one goal means accepting limitations on the others. Most directors inherit a structure rather than design one from scratch. Changing structure requires legislation, civil service reform, and years of negotiation. On the exam, though, you're asked to identify the ideal match. Read the goal, name the tool. When an exam question describes a leadership priority, the answer is whichever structure delivers that priority most reliably. Uniformity is centralized. Responsiveness is decentralized. Balance is mixed. Collaboration is shared. Identify the goal, and the structure follows automatically. Question 16. A county epidemiologist analyzes flu surveillance data, conducts a community needs survey, and publishes a report on local diabetes rates by zip code. These activities all involve gathering and interpreting health information about the population. Which of the three core public health functions do these activities represent? Your options are A. Assurance, the third core function. B. Assessment, the first core function. C. Policy development, the second core function. D. Coordination, a fourth core function. Got a guess? Lock it in. The correct answer is B. Assessment, the first core function. B is correct because assessment is the first core function and includes monitoring health status, diagnosing community problems, and conducting surveillance. The epidemiologist data analysis, needs survey, and rates report all fall within the standard scope of assessment activities. A is wrong because assurance is the third core function and focuses on enforcing laws, training the workforce, and linking patients to services. The activities described involve gathering and analyzing data, which is upstream of enforcement and service delivery. C is wrong because policy development is the second core function and covers informing, educating, empowering, and creating laws or regulations. The scenario describes gathering and publishing data, not creating policy, so the activities sit one function earlier. D is wrong because there is no fourth core function called coordination. The National Academy of Medicine identifies exactly three core functions: assessment, policy development, and assurance. Adding a fourth misrepresents the standard public health framework. Public health agencies organize their work around three core functions: assessment, policy development, and assurance. This framework, established by the Institute of Medicine in 1988, gave American public health a unified operational structure that every state and federal agency now follows. The sequence is deliberate. Assessment comes first because you cannot act on what you have not measured. Policy development comes second because identified problems require explicit responses. Assurance comes third because policies must be enforced and services actually delivered. Assessment encompasses everything an agency does to understand its population's health. Surveillance of reportable diseases, vital statistics, outbreak investigations, and community health needs assessments all live here. The function answers one question: what is actually happening in this population right now? When a question describes gathering, analyzing, or interpreting population health data, the answer is assessment. Watch for verbs like monitor, track, survey, investigate, and analyze. If the activity produces data and insight rather than creating policy or delivering a service, it belongs to assessment. Without solid assessment, every downstream public health activity rests on guesswork. It is the input the entire system depends on, which is exactly why the Institute of Medicine placed it first in the framework. Question 17. A state health commissioner drafts legislation to restrict tobacco sales near schools, launches an anti-smoking media campaign, and develops a comprehensive regulatory plan to lower youth smoking rates statewide. Which of the three core public health functions do these activities collectively represent in the standard framework? Your options are A. Assurance through enforcement of regulations. B. Assessment through community health monitoring. C. Policy development through informing and lawmaking. D. Service delivery through clinical care provision. Which one is it? Pause the video if you need more time. The correct answer is C. Policy development through informing and lawmaking. C is correct because policy development includes informing and educating the public, empowering communities, and developing laws and regulations. The Commissioner's tobacco campaign, school sales restriction, and regulatory plan all fall squarely within policy development activities. A is wrong because assurance enforces existing laws and regulations. Like FDA drug approval or nursing home oversight, the Commissioner is creating new policy and informing the public, which sits one function earlier than enforcement. B is wrong because assessment gathers and analyzes health data to identify problems and threats. The Commissioner is responding to identified problems by drafting laws and running campaigns, which fits the next function rather than the data gathering stage. D is wrong because service delivery is not one of the three core public health functions named by the National Academy of Medicine. The framework includes assessment, policy development, and assurance, with clinical service under assurance. Policy development is the second of the three core public health functions, the bridge between identifying a problem and enforcing a solution. It answers a fundamental question: what will we actually do about what we found? Assessment identifies the problem. Assurance enforces the response. Policy development sits in the middle, taking inputs from the assessment and producing outputs that assurance later carries out. Policy development includes two distinct activities. Educational work changes behavior through knowledge and motivation. Regulatory work changes behavior through formal rules with real consequences. In practice, most public health campaigns weave both threads together. The mechanism runs through legislative drafting, rulemaking, public communication, and stakeholder engagement. A state health agency might simultaneously run an anti-smoking media campaign and draft model legislation restricting tobacco sales. Each activity is policy development, working through its own pathway toward the same population-level goal. When an exam question describes activities that inform the public, educate communities, or develop new laws and regulations, the answer is policy development. Look for verbs like inform, educate, draft, advocate, and propose. If it creates or shapes policy, it belongs to the second core function. Question 18. A state health agency inspects nursing homes for compliance, fluoridates municipal water supplies, licenses public health nurses, and operates community health centers serving uninsured patients. These activities focus on enforcing rules and ensuring access to care. Which of the three core public health functions do they represent? Your options are A. Assurance through enforcement and access. B. Assessment through population data collection. C. Policy development through new lawmaking. D. Surveillance through outbreak investigation. Take a second. Which answer would you pick? The correct answer is A. Assurance through enforcement and access. A is correct because assurance is the third core function and includes enforcing laws, ensuring a competent workforce, and linking people to needed personal health services. Nursing home inspection, water fluoridation, licensure, and clinic operation all fit this function. B is wrong because assessment focuses on monitoring and diagnosing community health problems through data. The activities described involve enforcement and service provision rather than analysis, so they belong to a different stage of the public health framework. C is wrong because policy development creates laws and regulations and informs the public. The scenario describes enforcing existing rules and operating service infrastructure, which sits downstream of policy creation on the standard public health framework. D is wrong because surveillance is one specific assessment activity, not a core function in itself. The three core functions are assessment, policy development, and assurance, and surveillance falls under the first function rather than standing on its own. Assurance is the third core function of public health, and it is where the real operational work happens. If assessment identifies problems and policy development creates solutions, assurance is what makes those solutions real. Assurance spans an unusually broad scope, enforcing laws through inspections, licensing and training the healthcare workforce, delivering direct services like immunization clinics, and evaluating whether programs are actually producing results. Agencies need legal authority to inspect and enforce, professional staff to do the work, facilities to deliver services where the market does not reach, and evaluation systems to know whether any of it is working. When one piece is missing, the whole function breaks down. American public health history is full of laws that existed on paper, Continuum codes, food safety rules, disease reporting requirements, that only produce real outcomes when agencies invested in inspectors, labs, and training to make those rules operational. Watch for verbs like enforce, inspect, license, deliver, and evaluate. If the activity is making sure something happens or measuring whether it did, that is assurance, the function that converts policy on paper into health outcomes in the real world. Question 19. The National Academy of Medicine framework defines a small fixed set of core public health functions that organize all public health activity from data gathering through enforcement. A new public health professional studying the framework must memorize this set in order. Which option correctly names the three core functions? Your options are A. Surveillance, education, and inspection activities. B. Prevention, treatment, and rehabilitation services. C. Promotion, protection, and provision frameworks. D. Assessment, policy development, and assurance. Before I reveal it, which one do you think is right? The correct answer is D. Assessment, policy development, and assurance. D is correct because the National Academy of Medicine identifies the three core public health functions as assessment, policy development, and assurance. This framework is the standard taught in foundations courses and tested on certification exams across the field. A is wrong because surveillance, education, and inspection are specific activities within the core functions, not the functions themselves. Surveillance lives in assessment, education in policy development, and inspection in assurance. But these are not the named categories. B is wrong because prevention, treatment, and rehabilitation describe levels of medical care delivery, not the core functions of public health. The prevention continuum is a separate concept that organizes intervention timing rather than the framework structure. C is wrong because promotion, protection, and provision are concepts that appear in public health, goals, and activities, but are not the three core functions. The official framework uses different terminology drawn from the National Academy of Medicine report. Public health isn't a random collection of activities. It's organized around three core functions that flow in a deliberate sequence. This framework was established by the Institute of Medicine in 1988 and remains the standard organizing principle for American public health practice today. Assessment generates the data that drives policy development. Policy development creates the rules that assurance enforces. And assurance generates new data that feeds right back into assessment, a continuous cycle that repeats across every public health issue an agency addresses. Assessment means surveying and measuring population health. Policy development means crafting the standards and programs that respond to what assessment finds. Assurance means making sure those programs actually reach the people who need them, and measuring whether they work. Exam questions often substitute plausible sounding alternatives. Remember, only assessment, policy development, and assurance are the official terms. Related concepts like prevention levels or specific activities like surveillance and inspection describe pieces of the work. Not the framework itself. Data, rules, action. Each function feeds the others in a loop that never stops. When you see this question on the exam, the answer is always the same three official terms in that order. Question 20. A public health team responds to a measles outbreak in an elementary school. They count cases by classroom, draft a temporary mandatory vaccination order for the school district, and station a vaccinator at the school nurse office to deliver doses. Which functions are represented in order? Your options are A. Policy development, assessment, then assurance. B. Assessment, policy development, then assurance. C. Assurance, assessment, then policy development. D, assessment, assurance, then policy development. What's your answer? Commit to one before I continue. The correct answer is B. Assessment, policy development, then assurance. B is correct because counting cases is assessment because it gathers and interprets data. Drafting the vaccination order is policy development because it creates new regulation. Stationing a vaccinator delivers service and enforces vaccination, which is assurance. A is wrong because starting with policy development misorders the response. Counting classroom cases is data gathering, which is assessment, and it logically precedes drafting the vaccination order. So policy development cannot be the first function in the sequence. C is wrong because starting with assurance puts service delivery before data gathering and policy creation. The team has not yet defined the problem or written the rule when stationing the vaccinator, so this ordering reverses the workflow. D is wrong because placing assurance second skips policy development entirely. The vaccination order is a new regulation and must be classified as policy development, which sits between data gathering and enforcement in the framework. The three core public health functions aren't independent activities. They form a fixed, logical sequence that structures every public health response, whether it unfolds over hours or years. Assessment comes first because it produces the data that defines the problem. Policy development uses that data to design a response. Assurance then operates the response, enforcing rules, training staff, and delivering services. Each function produces exactly what the next one needs. In a measles outbreak at an elementary school, a team counts cases on Monday. That's assessment. By Tuesday, they draft a mandatory vaccination order to policy development. By Wednesday, a vaccinator is on site delivering doses, assurance. 3 days, 3 functions, 1 logical flow. The sequence isn't arbitrary, it reflects a logical dependency. Skipping or reversing any step creates incoherent practice. An agency missing the workforce for assurance, or the legal authority for policy, will fail at exactly the point that capability was needed. Whether a response spans 3 days or 3 years, the underlying flow is always the same. Count cases first, write rules second, deliver services third. Recognizing the verbs that signal each function lets you place any activity in its correct position in the sequence. Question 21. A community health worker assesses a neighborhood with high asthma rates and finds residents face unstable housing, food deserts, low-wage employment, and segregated schools with limited resources. These conditions all shape the residents' health outcomes through non-medical pathways. Which determinant of health category do these conditions represent? Your options are A. Behavioral determinants of health, B. Genetic determinants of health, C. Social determinants of health, D. Medical care determinants of health. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Social determinants of health. C is correct because social determinants of health include economic stability, education access, neighborhood quality, and the built environment. Housing, food access, employment, and schooling all fit this category, which captures conditions where people live, work, and learn. A is wrong because behavioral determinants involve individual choices like diet, exercise, smoking, or seatbelt use. Housing instability, food deserts, and segregated schools are environmental and economic conditions, not personal choices, so they sit outside the behavioral category. B is wrong because genetic determinants involve heredity and DNA-based traits influencing disease risk. The conditions described are entirely environmental and economic, with no reference to inherited traits. So the genetic category does not apply to this neighborhood scenario. D is wrong because medical care determinants involve access and quality of healthcare services. The scenario describes upstream conditions in housing, food, jobs, and schools rather than clinical service availability, missing the actual non-medical pathways involved. Beyond the clinic, 5 broad categories shape health: genetics, behavior, environment, medical care, and social factors. Of these, social determinants have become the dominant frame in modern public health because they explain more of the variation in health outcomes than the medical system alone ever could. Research consistently shows that zip code predicts life expectancy more reliably than genetic profile, and educational attainment correlates with health outcomes more strongly than insurance access. The Healthy People 2030 framework formally elevated social determinants as a primary focus area for exactly this reason. The social determinants category itself breaks into 5 subcategories, each capturing conditions where people live, work, learn, and worship, income instability, food deserts, housing insecurity, school quality, and social isolation all belong here, even though none resembles a traditional medical concern. Social determinants act upstream of individual choice. Chronic stress from unstable housing elevates cortisol and accelerates cardiovascular disease. A child in under-resourced schools faces constrained job prospects decades later. The pathways through the body are biological, but the root causes are social and structural. When an exam question describes housing, food access, employment, school quality, or neighborhood resources, the answer is social determinants of health. If the condition is upstream of personal choice and clinical care, it belongs in this category, and clinical care alone cannot fix it. Question 22. A primary care physician counsels a 45-year-old patient about smoking cessation, weight loss, regular exercise, alcohol moderation, and consistent seatbelt use. These topics all involve choices the patient makes daily that influence long-term health risks. Which determinant of health category does this counseling primarily address? Your options are A. Behavior, the choices and lifestyle category. B. Social factors, the economic conditions category. C. Genetics, the heredity and DNA category. D. Environmental, the natural and built category. Which would you go with? Lock it in before the reveal. The correct answer is A. Behavior, the choices and lifestyle category. A is correct because behavior as a determinant of health includes the actions and choices individuals make affecting well-being, such as smoking, diet, exercise, alcohol use, and seatbelt habits. The counseling topics map directly onto this established category. B is wrong because social factors involve economic stability, education, and neighborhood conditions rather than personal lifestyle choices. The counseling addresses individual habits the patient controls daily, which sits in a different determinant category from social factors entirely. C is wrong because genetics covers inherited traits and DNA-based health risks the patient cannot directly modify. The counseling addresses modifiable lifestyle behaviors rather than family history, so this category misses the focus of the conversation. D is wrong because environmental and physical influences include air and water quality, housing, and built spaces around the patient. The counseling topics focus on personal choices the patient controls, which is distinct from the surrounding environment. Behavioral determinants of health are the personal choices and daily actions that directly shape an individual's well-being. Unlike genetics or the environment, these factors sit within the realm of individual control and clinical influence. The behavioral category includes a wide range of everyday habits. What makes them distinctive is that they are modifiable. WGU. A clinician can directly counsel a patient on each one during a single office visit. The mechanism is cumulative biological exposure. A person who smokes for decades develops chronic lung inflammation. A person who walks daily lowers blood pressure and improves metabolic function. The dose-response relationship between behavior and biology is well established, making behavior change one of the highest yield interventions in public health. Behavioral determinants don't exist in isolation. A person's choice to smoke is influenced by neighborhood norms, tobacco marketing, and cigarette affordability. Public health labels the proximal choice as behavioral, but recognizes that social and environmental forces upstream shape what choices feel possible. When an exam stem describes something a person personally chooses to do or avoid each day, smoking, diet, exercise, alcohol, seatbelts, or treatment adherence, that is a behavioral determinant of health. It is the category most accessible to individual control and clinical counseling. Question 23. A public health investigator examines elevated childhood lead levels in an older urban neighborhood and finds aging water pipes, lead-based paint in pre-1978 housing, and proximity to a former industrial site contaminating local soil. Which determinant of health category best describes these contributing factors? Your options are A. Social factors involving income and education. B. Behavioral choices involving daily lifestyle habits. C. Medical care involving healthcare service quality. D. Environmental and physical influences. Don't overthink it. Which one feels right? The correct answer is D. Environmental and physical influences. D is correct because environmental and physical influences include both natural environment factors like air and water, and built environment factors like housing and infrastructure. Aging pipes, lead paint, and contaminated soil all sit squarely within this determinant category. A is wrong because social factors include income, education, and neighborhood economic conditions. The scenario focuses on physical contaminants in pipes, paint, and soil rather than economic or social structures, so social factors do not fit here. B is wrong because behavioral determinants involve personal choices like smoking or diet. The scenario describes physical exposure from infrastructure and industrial contamination, which children cannot control through behavior change, so the behavioral category does not capture the cause. C is wrong because medical care covers healthcare access and quality of clinical services. The scenario describes exposure pathways in homes and the surrounding environment rather than healthcare delivery, so medical care does not match the lead level context. Environmental and physical influences on health encompass everything in the physical world that surrounds people, both the natural environment they're born into and the built environment humans have constructed around them. The natural side includes elements largely outside human control. Yes, die weet hoe te als seit, weather, disease vectors, and geographic features. The built side includes everything humans construct, from water pipes and roads to neighborhood design. Public health intervenes in both, but through very different tools. Environmental determinants reach the body through two main pathways. Direct exposure means a hazard physically enters the body, like lead from aging pipes entering a child's bloodstream. Indirect influence means the environment shapes behavior, like a sidewalk-free neighborhood discouraging walking and quietly raising cardiovascular risk. Crucially, environmental health problems require infrastructure and policy responses, not clinical care or behavioral counseling. Replacing lead pipes, enforcing housing codes, and regulating air quality demand coordination across sectors like transportation, housing, and industry that are not traditionally health-focused. When an exam question describes pollution, contaminated water, aging infrastructure, workplace hazards, or disaster exposure, the answer is environmental and physical influences. The response belongs in infrastructure and policy, not in a clinic or a behavioral change program. Question 24. A rural county study finds that residents with health insurance and a usual source of primary care have significantly better blood pressure control than uninsured residents who rely on emergency departments for episodic visits. Which determinant of health category does this disparity in clinical access best represent? Your options are A. Behavioral determinants of personal lifestyle choices. B. Medical care determinants of healthcare access. C. Social determinants of community economic structure. D. Genetic determinants of inherited cardiovascular risk. Got a guess? Lock it in. The correct answer is B. Medical care determinants of healthcare access. B is correct because medical care as a determinant covers access, quality, and use of healthcare services that prevent, diagnose, and treat conditions. Insurance status and consistent primary care fit this category and explain the blood pressure gap. A is wrong because behavioral determinants involve daily lifestyle choices like diet, exercise, and smoking. The scenario contrasts insurance status and source of care, which are healthcare delivery features rather than individual lifestyle behaviors of rural residents. C is wrong because social determinants include broad economic and educational conditions. While insurance is influenced by social factors, the question frames the gap in terms of clinical access and care use, which medical care captures directly. D is wrong because genetic determinants involve inherited traits influencing cardiovascular risk. The scenario shows differences tied to insurance and care source rather than family history, so the gap reflects healthcare access patterns rather than population genetic differences. Medical care is one of the core determinants of health, but its role is more specific and more limited than most people assume. It captures whether people can actually access, receive, and benefit from clinical services. Medical care access has 4 distinct dimensions. A person can have insurance but no nearby provider. They can have a provider but face a language barrier. And even when care is reached, it may not meet evidence-based standards. Any one of these failures alone can produce worse health outcomes. The mechanism runs as a cascade. With insurance and a primary care provider, people get screened early and treated consistently. Without those resources, care becomes episodic and reactive. Late diagnoses and inconsistent treatment that compound over time. The same underlying condition produces very different outcomes based entirely on access. Medical care directly accounts for only 10 to 20% of population health outcomes, meaningful but smaller than most people expect. The remaining 80 to 90% is driven by social, behavioral, environmental, and genetic factors. This is precisely why public health must extend well beyond the clinical encounter. On the exam, medical care questions focus on whether and how patients receive clinical services. If the scenario describes insurance status, source of care, or care quality differences, that points to medical care determinants, not upstream social or behavioral factors. Question 25. A genetic counselor evaluates a 38-year-old woman whose mother and 2 maternal aunts developed breast cancer before age 50. The counselor discusses BRCA gene testing and inherited cancer susceptibility based on the documented family pattern. Which determinant of health category does this clinical workup primarily address? Your options are A. Social factors driving family economic stress. B. Behavior, the modifiable lifestyle category. C. Genetics, the heredity and DNA category. D. Medical care, the access and quality category. Which one is it? Pause the video if you need more time. The correct answer is C. Genetics, the heredity and DNA category. C is correct because genetics as a determinant covers genes and heredity, including DNA-based traits that influence disease development. BRCA mutation evaluation in a family with multiple early breast cancers fits this category exactly as taught in the framework. A is wrong because social factors involve economic stability, neighborhood, and education conditions affecting health. The counseling concerns inherited cancer susceptibility through family history rather than the family's economic circumstances, so the social determinant category does not match. B is wrong because behavior covers modifiable lifestyle choices like smoking, diet, or exercise. While behavior can influence cancer risk, the counseling specifically addresses inherited gene mutations passed through generations, which falls outside the behavioral determinants category entirely. D is wrong because medical care covers access, quality, and use of healthcare services. While the workup occurs in a clinical setting, the underlying determinant being assessed is heredity rather than healthcare access or service quality features. Genetic determinants of health are the inherited DNA-based traits and variations that shape an individual's baseline disease, risk, and biological function. This is the heredity category, where your biological story begins. The genetic category spans single gene disorders, complex polygenic patterns seen through family history, and pharmacogenomics, which predicts how a person responds to specific medications based on their DNA. Genetics sets the biological baseline, but behavior, environment, and medical care all shape what happens to that baseline across a lifetime. A BRCA1 mutation raises cancer risk significantly, EET says, yet prophylactic surgery or intensive screening can substantially reduce it. After the Human Genome Project completed in 2003, specific gene tests became clinically available. BRCA mutations predict breast and ovarian cancer risk. Lynch syndrome flags colorectal cancer risk, and hereditary cardiomyopathy tests identify dangerous cardiac conditions, all translating molecular biology into actionable prevention planning. On exam questions, if the STEM describes an inherited mutation, a multi-relative family history, or a genetic counseling scenario, the answer is genetic determinants, not behavior, environment, or medical care. Genetics sets the baseline, everything else modifies the path. Question 26. A 46-year-old man whose father, uncle, and older brother all had heart attacks before age 60 schedules a cardiology consultation after his 50th birthday. He tells his physician he feels his risk of heart disease is significantly elevated. Which health belief model component does this statement reflect? Your options are A. Perceived susceptibility, his sense of vulnerability. B. Perceived severity, the seriousness of disease. C. Perceived benefits, the value of taking action. D. Cues to action, the external trigger. Take a second, which answer would you pick? The correct answer is A. Perceived susceptibility, his sense of vulnerability. A is correct because perceived susceptibility is an individual's sense of personal vulnerability to a specific health condition. The patient's belief that family history places him at elevated heart disease risk maps directly onto this health belief model component. B is wrong because perceived severity captures how seriously the patient views the consequences of disease, not whether he will get it. The patient's statement is about likelihood of disease rather than how bad the disease itself would be. C is wrong because perceived benefits address whether the patient believes a recommended action will reduce risk. The patient's statement is about his vulnerability to disease rather than about evaluating the value of any specific preventive intervention or screening. D is wrong because cues to action or external triggers like media campaigns, provider recommendations, or family events that prompt behavior. The patient's perception of vulnerability is internal belief, not an external prompt pushing him toward action. The health belief model is one of the oldest frameworks in public health, developed in the 1950s to explain why people fail to act on health recommendations even when those actions are free and available. The model proposes 6 separable components: susceptibility, severity, benefits, barriers, cues to action, and self-efficacy each independently shape whether a person takes preventive action, and an intervention can target any one of them specifically. Perceived susceptibility is the entry point of the model. A person who does not feel personally at risk will not seek prevention, regardless of how effective or easy the recommended action is. Family history, personal experience, and targeted risk communication can all raise perceived susceptibility. Once a person feels genuinely vulnerable, preventive behavior follows, and that shift is the lever public health interventions pull. When a question describes a patient stating how likely they believe they are to develop a condition, that is perceived susceptibility, not severity, not barriers, not self-efficacy. It is always about the personal vulnerability belief. Question 27. A patient with newly diagnosed type 2 diabetes tells the diabetes educator she now understands uncontrolled blood sugar can lead to amputation, blindness, kidney failure, and stroke. She sees these complications scare her enough to commit to her medication and dietary plan. Which health belief model component is this? Your options are A. Self-efficacy and managing diabetes daily. B. Perceived benefits of glycemic control. C. Cues to action from external campaigns. D. Perceived severity of disease consequences. Before I reveal it, which one do you think is right? The correct answer is D. Perceived severity of disease consequences. D is correct because perceived severity is the patient's belief about how serious a condition is and how bad the consequences could be. Recognition of amputation, blindness, kidney failure, and stroke fits this health belief model component. A is wrong because self-efficacy reflects the patient's confidence in her ability to perform recommended actions. The statement focuses on how serious the consequences would be, rather than whether she believes she can manage medication and diet effectively. B is wrong because perceived benefits address whether the patient thinks the action will reduce her risk. The statement focuses on the consequences of inaction, rather than her evaluation of how much glycemic control would lower complication risk. C is wrong because cues to action are external prompts like a public health campaign, provide a phone call, or news story. The patient's recognition of disease seriousness comes from internal understanding rather than from a specific external trigger. Perceived severity is the second core component of the health belief model. It captures how serious a person believes a disease would be, not just medically, but across every dimension of their life. Severity in the health belief model spans medical consequences like stroke and organ failure, but also functional and social consequences, the inability to work, dependence on family, and loss of meaningful life experiences. Framing severity across all these dimensions produces stronger behavior change than focusing on clinical complications alone. Perceived susceptibility and perceived severity are independent beliefs. Susceptibility is about the likelihood of getting the disease. Severity is about the consequences of having it. Both must be present for strong preventive action. A person who feels vulnerable but not threatened is unlikely to act. And neither is a person who sees the disease as serious but thinks it cannot happen to them. When a diabetes educator walks a patient through amputation, blindness, and kidney failure as real personal possibilities, severity shifts from abstract knowledge to emotional commitment. Narrative, storytelling, and patient testimonials work because they make severity concrete, and concrete severity changes behavior in ways that statistics rarely do. On exam questions, perceived severity appears whenever a patient expresses belief about how serious or life-altering a disease would be. If the statement is about consequences rather than likelihood, the answer is perceived severity, the second of the 6 health belief model components. Question 28. A 52-year-old woman tells her primary care provider she will get her first colonoscopy because she has read that polyp removal during the procedure substantially lowers her future colon cancer risk. She believes the screening is worth the inconvenience. Which health belief model component drives this decision? Your options are A. Perceived barriers limiting her willingness. B. Perceived benefits of taking the action. C. Cues to action from her physician's recommendation. D. Perceived susceptibility to colorectal cancer. What's your answer? Commit to one before I continue. The correct answer is B. Perceived benefits of taking the action. B is correct because perceived benefits capture the patient's belief that a recommended action will reduce her susceptibility or severity. Believing that polyp removal during colonoscopy meaningfully cuts cancer risk fits this health belief model component squarely as defined. A is wrong because perceived barriers are obstacles the patient sees in taking action, like cost, time, or fear. The patient is leaning towards the screening rather than away from it. So the dominant component is not the obstacles. C is wrong because cues to action are external triggers like a provider recommendation or media campaign. The scenario does not describe a triggering event, but rather the patient's weighing of the action's value, which fits a different component. D is wrong because perceived susceptibility is the patient's belief about her vulnerability to disease. The scenario focuses on the value of polyp removal in reducing risk rather than on whether she feels personally vulnerable to colorectal cancer. The health belief model has a crucial third component called perceived benefits, the belief that a recommended action will actually reduce a health threat. This is where threat awareness gets converted into real behavior change. Even when someone knows they are at risk and understands the seriousness of a disease, they still won't act unless they believe the recommended action will work. Perceived benefits is the belief that the action delivers meaningful protection. Perceived benefits sits at the center of the model's logic. High susceptibility and high severity create threat awareness, but perceived benefits is the bridge that actually carries a person from recognizing the threat to taking protective action. People update their benefits beliefs based on credible evidence, first-hand experience, and trusted messengers. A friend who had polyps removed during a colonoscopy is more persuasive than an abstract statistic. Public health communication works best when it delivers concrete, credible benefit information. On the exam, look for patients evaluating whether a recommended action will actually lower their risk. Statements like, "I believe the screening will find disease," or "the vaccine will protect me." If the belief is about the action's effectiveness rather than the threat or the obstacles, the answer is perceived benefits. Question 29. A patient understands she should get a screening mammogram, but tells the nurse she works 2 jobs, has no childcare on weekdays, faces a high copay, and fears the discomfort of the procedure. These obstacles keep her from scheduling the appointment. Which health belief model component dominates here? Your options are A. Cues to action from external campaigns. B. Perceived susceptibility to breast cancer risk. C. Perceived barriers to taking the action. D. Self-efficacy in completing the screening. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Perceived barriers to taking the action. C is correct because perceived barriers are obstacles or costs the patient associates with taking the action, like time, money, childcare, or discomfort. 2 jobs, no childcare, copay, and procedure feel all map onto this health belief model component. A is wrong because cues to action are external triggers that prompt behavior. The scenario describes obstacles preventing the patient from acting, not external prompts pushing her towards screening. So the dominant component is the opposite of cues. B is wrong because perceived susceptibility captures the patient's sense of personal vulnerability to breast cancer. The scenario does not describe how vulnerable she feels, but rather the practical and emotional obstacles between her and the recommended screening. D is wrong because self-efficacy reflects the patient's confidence in her ability to perform the action successfully. The scenario describes external life obstacles rather than her internal sense of capability, so this component does not capture the dominant force. Perceived barriers is the fourth core component of the health belief model. It captures every obstacle a patient sees standing between them and a recommended health action, and it functions as the negative weight in their internal cost-benefit calculation. Barriers fall into structural, practical, and emotional categories. Structural and practical barriers are often visible and concrete. Emotional and psychological barriers, fear of bad news, shame, or provider distrust, are frequently invisible unless a clinician asks directly. Think of the patient running an internal scale. When barriers outweigh benefits, action stops. When a public health intervention removes even one specific barrier, a sliding scale copay, weekend clinic hours, a mobile van, the scale tips and the behavior becomes more likely, without requiring any change in the patient's beliefs about disease risk. Barrier reduction is a high-yield intervention strategy precisely because barriers are concrete and addressable. Structural barriers respond to free services and flexible hours. Emotional and psychological barriers respond to skilled communication, peer support, and trauma-informed care. On the exam, whenever a patient describes what stands between them and taking action, cost, time, fear, embarrassment, that is the perceived barriers component. The model treats these as predictable and removable, which is what makes barrier reduction so powerful in public health practice. Question 30. A grandmother sees a televised public service announcement urging people over 65 to get the updated COVID-19 booster, then receives a postcard from her primary care office reminding her to schedule. She calls the next morning to book her appointment. Which health belief model component is operating here? Your options are A. Cues to action from external triggers. B. Perceived severity of COVID complications. C. Perceived susceptibility from age over 65. D. Perceived benefits of vaccine effectiveness. Which would you go with? Lock it in before the reveal. The correct answer is A. Cues to action from external triggers. A is correct because cues to action are external factors like media campaigns, provider reminders, or family experiences that prompt the individual to take a recommended action. The PSA and postcard reminder both fit this health belief model component. B is wrong because perceived severity captures the patient's belief about how serious disease consequences would be. The scenario does not describe what she thinks about the dangers of COVID, but rather what external prompts moved her to schedule. C is wrong because perceived susceptibility is the patient's sense of her vulnerability to disease. While being over 65 does increase risk, the scenario emphasizes the external triggers that prompted her action rather than internal sense of vulnerability. D is wrong because perceived benefits address how much the patient believes the action will reduce risk. The scenario focuses on what triggered her action rather than her evaluation of booster effectiveness, so this component does not fit. The health belief model identifies 5 core components, and cues to action is the one that actually moves a patient from intention into behavior. It's the external trigger that closes the gap between believing you should act and actually acting. Cues can be almost anything external: a clinic postcard, a PSA, a phone call, even watching a family member get sick. What they share is that they come from outside the patient and make action feel immediate and concrete rather than abstract. Even when all the internal beliefs are perfectly aligned, a patient knows the risk, understands the severity, sees the benefits, and feels the barriers are manageable. Action still often doesn't happen until a specific external prompt arrives. A cue is most powerful when it arrives at the right moment. A vaccine reminder during flu season, a mammogram postcard on a patient's birthday. Timing, salience, and pre-existing beliefs combine to make the cue actionable. Public health campaigns engineer this by layering multiple cues across multiple channels. Cues to action is the only health belief model component that is fully external, which is exactly why public health practitioners can engineer it through campaigns and outreach. If the question describes an outside prompt converting intention into behavior, that's your answer. Question 31. A primary care physician encourages a 38-year-old patient to quit smoking. The patient laughs and says smoking is fine, he has no plans to stop, and he does not see a problem with his current habit. Which stage of the stages of change model does this patient occupy? Your options are A. Maintenance, where habits are sustained over time. B. Action, where behavior change is actively underway. C. Preparation, where small changes begin happening. D. Pre-contemplation, where change is not considered. Don't overthink it. Which one feels right? The correct answer is D. Pre-contemplation, where change is not considered. D is correct because pre-contemplation describes patients not considering change, often unaware of the need, and showing resistance or denial. The patient laughs off the suggestion and sees no problem, fitting pre-contemplation exactly as defined in the model. A is wrong because maintenance occurs after successful change has been sustained, with focus on preventing relapse. The patient has not changed anything yet and rejects the idea of change, placing him at the opposite end of the model. B is wrong because action involves actively modifying behavior using specific strategies. The patient has not started any change behavior and shows no intention to begin, so the action stage does not fit the office visit conversation. C is wrong because preparation involves planning a behavior change soon, often within 30 days, with goal setting and small steps underway. The patient is not preparing anything and rejects the need for change, excluding the preparation stage. The trans-theoretical model, developed by Prochaska and De Clemente in the late 1970s, grew out of research on how people successfully quit smoking. Their key insight was that behavior change is a process, not a single event. The model identifies 5 core stages: pre-contemplation, contemplation, preparation, action, and maintenance, with an optional 6th stage of termination. Each stage represents a different level of readiness, and effective interventions must be matched to where the patient actually is, not where the clinician wants them to be. Pre-contemplation is the first stage, defined by the absence of internal motivation. The patient either does not recognize the behavior as problematic or acknowledges it but remains in denial. Aggressive action-focused interventions at this stage typically produce pushback or disengagement. The appropriate clinical approach in pre-contemplation is to offer brief, non-judgmental information about risks, build rapport, and leave an open invitation to revisit the topic. The goal is simply to nudge the patient toward contemplation, where the real work of change can begin. Question 32. A 42-year-old woman with hypertension tells her nurse she has been weighing the pros and cons of starting a daily walking routine. She says she sees the benefits but also the time it will take. She is not yet committed to starting. Which stage of change does she occupy? Your options are A. Action, with active behavior modification. B. Contemplation, where pros and cons are weighed. C. Maintenance, with sustained change over time. D. Pre-contemplation, with no awareness of need. Got a guess? Lock it in. The correct answer is B. Contemplation, where pros and cons are weighed. B is correct because contemplation occurs when individuals become aware of the need for change and start weighing pros and cons, often with ambivalence. The patient's weighing of benefits against time costs fits contemplation exactly as defined. A is wrong because action involves actively modifying behavior, environment, or both with concrete strategies underway. The patient has not started walking and remains uncommitted to change, so she sits at an earlier stage than action. C is wrong because maintenance occurs after months of sustained behavior change, with focus on preventing relapse. The patient has not yet started walking, much less sustained the new habit, so she sits far earlier than maintenance. D is wrong because pre-contemplation describes patients with no awareness of the need for change. The patient explicitly recognizes the value of walking and is weighing whether to start, meaning she has moved past pre-contemplation into the next stage. Contemplation is the second stage of the stages of change model. The patient recognizes that change is needed but hasn't yet committed to acting. What defines this stage isn't ignorance, it's ambivalence. The patient actively weighs both sides, the appeal of change against its perceived costs, and the comfort of staying the same against its harms. This internal tension can persist for months or even years without resolving into action. Living with the awareness that a behavior is harmful while not being ready to change it generates ongoing cognitive dissonance. Patients resolve this tension in different directions. Some move forward into planning. Others rationalize their way back into pre-contemplation. Because the patient already has information, the intervention is motivational, not instructional. Motivational interviewing uses open-ended questions, reflective listening, and affirmation to help patients explore their own reasons for change. Pressure or direct advice typically extends the stage rather than shortening it. When a question describes a patient who is thinking it over, considering the trade-offs, or not yet committed to acting, the answer is contemplation. The goal is to tip the balance, not to push, but to help them work through their specific ambivalence toward preparation. Question 33. A patient tells her diabetes educator she has decided to start checking her fasting blood sugar daily, has bought a new glucometer, downloaded a tracking app, and chosen next Monday as her start date. She has not yet logged her first reading. Which stage of change is she in? Your options are A. Maintenance with sustained tracking over months. B. Contemplation with weighing of pros and cons. C. Preparation with concrete planning before action. D. Termination with full integration of the behavior. Which one is it? Pause the video if you need more time. The correct answer is C. Preparation with concrete planning before action. C is correct because preparation involves having decided to make a change and actively preparing to act soon, often setting goals, gathering tools, and making small initial changes. The glucometer purchase, app download, and start date fit exactly. A is wrong because maintenance occurs after the new behavior has been sustained for several months. The patient has not yet logged her first reading, meaning she has not started the action stage, much less qualified for maintenance. B is wrong because contemplation involves weighing pros and cons without firm commitment. The patient has decided to act, set a start date, bought equipment, and downloaded an app, moving her past the ambivalence that defines contemplation. D is wrong because termination is the ultimate stage where temptation no longer exists and the behavior is fully integrated into lifestyle. The patient has not yet started checking her sugar, so she is many stages from full integration. Preparation is the third stage of the stages of change model, the bridge between deciding to change and actually doing it. The patient has resolved ambivalence and is now actively getting ready. The defining feature of preparation is concrete planning. The patient sets goals, gathers tools, chooses a start date, and makes small early moves that build toward full behavior change. This stage typically lasts weeks, not months. Research by Prochaska and Da Clemente found that patients who skipped preparation and jumped straight from contemplation to action had significantly higher relapse rates. They started without the structures and supports needed to sustain change. The intervention strategy shifts from motivational to practical. The patient already wants to change. Now they need help planning. Clinicians act as planning partners, helping identify obstacles in advance and build a concrete, realistic action plan. On the exam, look for patients who have committed to change and are actively preparing. Okay, buying equipment, setting start dates, or making small initial changes. If the full behavior hasn't started yet, but planning is underway, the answer is preparation. Question 34. A previously sedentary man has been jogging 3 mornings a week, packing healthy lunches, and tracking calories in an app for the past 6 weeks. He says these new habits feel difficult, but he is sticking with them. Which stage of change does this fit? Your options are A. Action, where new behaviors are actively underway. B. Contemplation, where change is being considered. C. Preparation, where small steps are starting. D. Pre-contemplation, where change is not considered. Take a second. Which answer would you pick? The correct answer is A. Action, where new behaviors are actively underway. A is correct because action involves implementing specific strategies to bring about behavior change, with new habits actively underway. The man has been jogging, packing lunches, and tracking food for 6 weeks, fitting the active modification phase exactly. B is wrong because contemplation involves weighing the pros and cons of change without committing to action. The man has already committed and is performing the new behaviors regularly, moving him well past the deliberation stage of the model. C is wrong because preparation involves planning and initial small steps before sustained behavior change begins. The man is performing established new behaviors over 6 weeks rather than just preparing, placing him at the next stage on the continuum. D is wrong because pre-contemplation describes patients who are not considering change at all. The man is actively jogging, packing lunches, and tracking calories, placing him at the opposite end of the continuum from the no awareness start. The action stage is the 4th step in the stages of change model, the period when a person is actively performing a new behavior. It's what most of us picture when we think of change, but in this model it's just one chapter in a longer journey. The action stage is defined by visible behavior change paired with conscious effort to sustain it. The new behavior is real and happening, but it isn't automatic yet. Every day still requires deliberate work, and the old behavior remains psychologically available as a fallback. Research on relapse rates revealed a clear pattern. People who sustained a new behavior for at least 6 months without lapse showed dramatically lower relapse rates afterward. This empirical finding established the 6-month threshold that separates action from the next stage, maintenance. Clinicians working with patients in action operate as coaches, not persuaders. The 3 core tasks are validating the real work the patient is doing, troubleshooting specific obstacles as they arise, and helping the patient distinguish a momentary lapse from a full relapse, a distinction that research shows actually reduces relapse rates. On the exam, look for patients actively performing a new behavior for weeks or months but still finding it hard. That combination, new behavior underway, conscious effort, recent start, points to action every time. Question 35. A nurse follows a patient who quit smoking 16 months ago. The patient still attends a quarterly support group, avoids old smoking triggers, and uses planned coping strategies during stressful periods to prevent relapse. She no longer feels active cravings most days. Which stage of change applies here? Your options are A. Action, where new behavior is being established. B. Preparation, with small initial changes underway. C. Contemplation, where pros and cons are weighed. D. Maintenance, with sustained behavior and relapse prevention. Before I reveal it, which one do you think is right? The correct answer is D. Maintenance with sustained behavior and relapse prevention. D is correct because maintenance occurs after successful change, focusing on sustaining new behavior over the long term and preventing relapse. The patient's 16-month smoke-free period, support group attendance, and trigger avoidance map onto maintenance activities. A is wrong because action describes the first 6 months of new behavior, where the patient is actively modifying behavior with effort. The patient has been smoke-free for 16 months and uses relapse prevention strategies past the action time frame. B is wrong because preparation involves making small initial changes and planning the action stage. The patient quit over a year ago, has sustained the change, and actively prevents relapse, which is several stages beyond preparation in the model. C is wrong because contemplation involves weighing pros and cons of change before committing. The patient already quit smoking 16 months ago and is sustaining the change, so the deliberation stage no longer applies to her current behavior pattern. The maintenance stage is the 5th stage of the stages of change model, beginning after a new behavior has been sustained for at least 6 months. Unlike the action stage, maintenance is defined not by learning the behavior, but by keeping it alive against the pull of relapse. The defining features are reduced cognitive load and ongoing vigilance. The behavior runs with less conscious effort than during action, but the patient actively monitors for relapse risk rather than assuming the change is permanent. Maintenance interventions are structural rather than motivational. Support groups, peer relationships, environmental changes, and pre-planned coping strategies embed the behavior deeply enough to survive predictable life disruptions like stress, depression, or social pressure from old contacts. Patients who stay in maintenance longest are those with explicit strategies for high-risk moments. Willpower alone is insufficient. Stress, emotional events, life transitions, and social settings can destabilize even years of sustained change without these structures in place. On the exam, look for patients past the 6-month mark who are still attending support groups, avoiding triggers, and using coping strategies. That active relapse prevention work is what separates maintenance from simply having changed. The model treats the stage as long and effortful, not as the finish line. Question 36. A public health student studies the foundational disease transmission framework that identifies 3 interacting elements responsible for disease spread. Understanding all 3 is essential for designing effective control measures and predicting outbreak patterns. Which option correctly names the 3 components of the epidemiologic triangle? Your options are A. Vector, reservoir and pathogen elements. B. Agent, host and environment components. C. Susceptibility, exposure and infection stages. D. Pathogen, person and place factors. What's your answer? Commit to one before I continue. The correct answer is B. Agent, host and environment components. B is correct because agent, host, and environment are the 3 components of the epidemiologic triangle. Agent is the disease cause, host is the susceptible organism, and environment includes the external factors affecting both. Completing the framework. A is wrong because vector, reservoir, and pathogen are concepts in disease transmission but are not the 3 components of the epidemiologic triangle. The triangle uses different category names that group these concepts under broader headings. C is wrong because susceptibility, exposure, and infection describe stages of the disease process within a host, but do not name the 3 sides of the epidemiologic triangle. The triangle uses different terminology focused on cause, host, and surroundings. D is wrong because pathogen, person, and place are useful informal labels but are not the official epidemiologic triangle terms. The textbook framework uses agent, host, and environment as its standard component names in foundations of public health courses. The epidemiologic triangle is the foundational framework for understanding why disease occurs. It tells us that no single factor causes disease alone. It takes the alignment of three interacting components. The agent is the cause of disease, a pathogen, toxin, or behavioral exposure. The host is the susceptible organism. The environment is everything external that shapes how agent and host interact. Disease only occurs when all three sides line up. A pathogen present without a susceptible host, or without the right environmental conditions for transmission, will not produce an outbreak. Break any one side of the triangle and you interrupt disease occurrence. Public health works by deliberately disrupting the alignment of the triangle. Vaccination strengthens the host. Sanitation eliminates the agent. Vector control alters the environment. Every major intervention maps onto at least one vertex of this model. The triangle's power is that it forces thinking beyond the pathogen alone. Host, susceptibility, and environmental conditions together explain why the same agent produces very different disease patterns across populations and settings. Question 37. A microbiologist isolates the bacterium Vibrio cholerae from a contaminated water sample during an outbreak investigation. The organism's ability to cause cholera in humans places it within a specific component of the epidemiologic triangle framework. Which component does this disease-causing organism represent in the triangle? Your options are A. Host, the susceptible organism harboring disease. B. Environment, the external factors affecting transmission. C. Agent, the cause of the disease itself. D. Vector, the carrier transmitting the disease. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Agent, the cause of the disease itself. C is correct because agent is the factor that causes disease. Often a microorganism like a virus, bacterium, or parasite. Vibrio cholerae is the bacterium causing cholera and fits the agent component of the epidemiologic triangle exactly. A is wrong because host refers to the living being susceptible to or harboring the disease-causing organism. The bacterium itself is the cause of disease rather than the susceptible victim. So this component does not fit the organism's role. B is wrong because environment refers to external factors influencing the agent and host interaction, like climate, geography, or living conditions. The bacterium itself is the cause rather than a contextual factor, so environment does not capture its role. D is wrong because vector is a separate concept describing a living carrier transmitting a pathogen, like a mosquito carrying malaria, while vectors exist in transmission models. The epidemiologic triangle uses agent, host, and environment as its three categories. In the epidemiologic triangle, the agent is the factor that actually causes disease. Understanding what an agent is and how it works is foundational to all of public health practice. Agents extend far beyond microorganisms, any factor that directly causes disease, biological, chemical, physical, or nutritional, counts as an agent in the triangle's logic. Each biological agent type damages the body through a distinct mechanism. Knowing the mechanism shapes how clinicians recognize the disease and how public health teams choose interventions to interrupt it. Identifying the agent is the first operational step in any outbreak investigation. Once the agent is confirmed, every downstream question, transmission route, treatment, prevention, becomes answerable. Modern molecular methods have made this process dramatically faster than traditional culture techniques. The agent is the cause, and identifying it unlocks the entire public health response, from targeted antimicrobials to sanitation campaigns to vaccination. On the exam, if a question describes what is causing the disease, the answer is agent. Question 38. An epidemiologist studying a hepatitis B outbreak identifies risk factors including unvaccinated status, age over 50, and chronic liver disease in those who develop severe illness. These traits affect each individual's susceptibility to the disease and severity of outcomes. Which component of the epidemiologic triangle do they reflect? Your options are A. Host factors influencing susceptibility and severity. B. Agent factors driving the pathogen's virulence. C. Environment factors shaping geographic exposure. D. Vector factors transmitting the disease between people. Which would you go with? Lock it in before the reveal. The correct answer is A. Host factors influencing susceptibility and severity. A is correct because host factors include genetics, immunity, age, and overall health, all of which influence susceptibility to disease and severity of outcomes. Vaccination status, age, and chronic liver disease all sit within the host component. B is wrong because agent factors involve characteristics of the pathogen itself, like infectivity, virulence, and antigenicity. Vaccination status and age are properties of the people being infected, rather than properties of the hepatitis B virus causing the disease. C is wrong because environment factors include geography, climate, and socioeconomic conditions affecting exposure. Vaccination, age, and chronic liver disease are intrinsic to the affected individuals rather than to the surroundings, so they belong to a different component category. D is wrong because vector is not one of the three named components of the epidemiologic triangle. The framework uses agent, host, and environment as its three categories, and individual susceptibility traits sit within the host component. The host is the second side of the epidemiologic triangle. The susceptible organism that develops disease after exposure to an agent. Unlike the pathogen itself, host factors are often modifiable, making the host side of the triangle a powerful target for public health intervention. Host factors span a wide range of individual characteristics. Together they determine how readily a person can be infected, how severely the disease will progress, and how quickly recovery will occur. The same pathogen can produce dramatically different outcomes depending on who it encounters. The same agent, two very different outcomes. A susceptible host with compromised immunity or chronic disease may develop severe illness, while a resistant host clears the infection asymptomatically. Host factors explain why disease burden is never evenly distributed across a population. Public health acts on the host side through three main levers. Vaccination directly converts susceptible individuals into resistant ones, and when enough people are immune. Herd immunity shields even those who are unvaccinated. Nutrition programs and chronic disease management raise baseline health, reducing overall population vulnerability. When a question describes characteristics of the individuals affected, we fair EMS, age, vaccination status, immunity, or chronic conditions. That is the host side of the triangle. The host is where vaccination programs intervene, converting susceptibility into resistance and bending the curve of infectious disease at the population level. Question 39. A public health investigator analyzes a tuberculosis outbreak in a homeless shelter and identifies overcrowded sleeping quarters, poor ventilation, shared bathroom facilities, and limited heating during winter months. These conditions all promote disease transmission. Which component of the epidemiologic triangle do they represent? Your options are agent factors driving the bacterium's pathogenicity. B. Host factors shaping individual susceptibility patterns. C. Vector factors carrying the pathogen between people. D. Environment factors influencing transmission conditions. Don't overthink it. Which one feels right? The correct answer is D. Environment factors influencing transmission conditions. D is correct because environment factors include physical, biological, social, and economic conditions like geography, climate, living conditions, and crowding. Overcrowded sleeping, poor ventilation, shared bathrooms, and inadequate heating all map directly onto the environment component as defined. A is wrong because agent factors involve the pathogen's intrinsic properties, like Mycobacterium tuberculosis virulence or infectivity, crowding, ventilation, and shared bathrooms are external conditions surrounding the pathogen rather than traits of the bacterium itself. B is wrong because host factors involve traits of susceptible individuals, like immune status or chronic disease. The conditions described are features of the shelter setting rather than the people being infected, placing them in a different component. C is wrong because vector factors describe living carriers that transmit pathogens, but tuberculosis spreads through airborne respiratory droplets rather than vectors. Even if vectors applied, they would not be one of the three named components of the triangle. The epidemiologic triangle has three sides: agent, host, and environment. Environment refers to the external conditions surrounding the agent-host interaction, and it's where many of the most powerful public health levers operate. Environmental conditions fall into three overlapping categories. Physical conditions include climate and crowding. Biological conditions include vector populations and animal reservoirs. Social and economic conditions include sanitation, infrastructure, housing quality, and poverty, all external to both the agent and the host. Environment shapes disease through three pathways: exposure intensity, transmission efficiency, and host vulnerability. Crowding increases exposure. Poor ventilation extends airborne pathogen viability. Inadequate heating weakens respiratory defenses. None of these involve the pathogen's biology or the individual's immunity. They operate at the structural level. Structural public health interventions work precisely by modifying the environment. Clean water systems prevent waterborne transmission across whole populations. Sewage management interrupts fecal-oral pathways. Vector control reduces mosquito-borne disease. Ventilation requirements cut respiratory transmission in shared spaces. Each breaks the agent-host interaction at scale. When an exam question describes crowding, ventilation, sanitation, climate, or living conditions shaping disease occurrence, the answer is environment. If it's external to both the agent and the host, it belongs on the third side of the triangle. Question 40. A virologist studying influenza describes the virus as having high infectivity because it readily establishes infection in exposed hosts, but generally lower virulence because most cases produce mild illness rather than severe disease. Which two pathogen properties is the virologist distinguishing in this description? Your options are A. Pathogenicity and antigenicity, disease and immune. B. Infectivity and virulence, establishment and severity. C. Susceptibility and resistance, the host immune properties. D. Transmission and incubation, spread and timing. Got a guess? Lock it in. The correct answer is B. Infectivity and virulence, establishment and severity. B is correct because infectivity is the ability of an agent to establish infection in a host, and virulence is how severely the agent causes disease. Flu being highly infectious but mostly mild illness fits these properties exactly. A is wrong because pathogenicity is the capacity to cause disease, and antigenicity is the ability to provoke immune response. The virologist discussed how readily infection establishes and how severely disease progresses, which uses different pathogen property terms entirely. C is wrong because susceptibility and resistance are host properties rather than agent properties. The virologist is describing characteristics of the influenza virus itself rather than characteristics of people being infected. So host site terms do not capture this. D is wrong because transmission and incubation describe how the disease spreads and the timing before symptoms appear. The virologist is describing how readily infection takes hold and how severe the resulting disease becomes, which uses different terms. Every disease agent can be characterized by 4 distinct properties that determine how it behaves in a host and spreads through populations. These are infectivity, pathogenicity, virulence, and antigenicity, and each measures something different. Infectivity is the probability that exposure leads to establishment. Pathogenicity is the probability that establishment leads to clinical illness. Virulence is how severe that illness becomes. Antigenicity is the strength of the immune response the agent provokes. Seasonal influenza illustrates how these properties operate independently. It has high infectivity because it establishes itself efficiently in exposed host, yet relatively low virulence because most cases remain mild. An agent's profile across all 4 dimensions shapes the appropriate public health response. Antigenicity deserves special attention because it underpins vaccine strategy. High antigenicity agents stimulate strong, long-lasting immunity after a single exposure or vaccination, while low antigenicity agents require repeated boosters and may still allow reinfection over time. On the exam, distractors swap these terms because they sound alike. Anchor each one to its core question. Did it take hold? Did it cause illness? How severe? Did it trigger immunity? Keep those 4 questions clear and the answers follow quickly. Question 41. A state epidemiology team learns of a possible measles cluster at a private elementary school. Team members travel to the school, interview families, examine students, and contact local clinicians directly to identify additional cases. Which type of surveillance does this proactive case-finding effort represent in public health practice? Your options are A. Passive surveillance through reporting databases. B. Sentinel surveillance through specialized clinics. C. Active surveillance through proactive case finding. D. Syndromic surveillance through electronic data feeds. Which one is it? Pause the video if you need more time. The correct answer is C. Active surveillance through proactive case finding. C is correct because active surveillance involves proactive efforts to seek out information from providers or the population, including outbreak investigations, interviews, and active case searches. The scenario fits exactly with school visits, interviews, and direct clinician contact. A is wrong because passive surveillance involves regular collection of health data from hospitals and clinics without active engagement, like reportable disease databases. The scenario describes investigators traveling and interviewing, the opposite of passive collection from existing reports. B is wrong because sentinel surveillance uses selected health providers reporting from specific sites to track disease trends. The scenario does not describe a sentinel network, but rather a directed outbreak investigation, which falls under a different surveillance category. D is wrong because syndromic surveillance uses real-time data like emergency department chief complaints to detect outbreaks early. The scenario describes targeted in-person investigation rather than automated data feeds, which makes syndromic surveillance the wrong category for this response. Active surveillance is the practice of proactively seeking out disease cases rather than waiting for reports to arrive. It stands in contrast to passive surveillance, where health systems simply receive whatever gets reported through routine channels. In active surveillance, investigators initiate contact with clinicians, hospitals, laboratories, patients, and communities. Each pathway requires dedicated staff time and travel, which is why active surveillance is deployed selectively for outbreaks or diseases where routine reporting is known to miss cases. The 2 approaches differ across several dimensions. Active surveillance is proactive, expensive, and produces more complete data but runs only for a defined period. Passive surveillance runs continuously at low cost but depends on cases finding their way into reporting systems on their own, often missing remote or undiagnosed cases. Active surveillance proved critical in polio eradication campaigns and the West Africa Ebola response, where routine reporting missed cases in remote or under-resourced settings. The additional cost is justified when the public health value of finding hidden cases is high, such as during a measles cluster investigation or a novel pathogen outbreak. On the exam, active surveillance is signaled by verbs like seek out, investigate, interview, and contact. If health workers are reaching out to find cases rather than receiving routine reports, that is active surveillance, proactive, expensive, and essential when completeness and timeliness matter most. Question 42. A state health department maintains a database of reportable diseases that hospitals and clinics submit weekly through standardized electronic forms. The department reviews this data monthly to track influenza, hepatitis B, and other notifiable conditions. No outreach to providers occurs unless an alert appears. Which surveillance type is this? Your options are A. Passive surveillance through standardized reporting. B. Active surveillance through provider outreach. C. Sentinel surveillance through selected reporting sites. D. Disaster surveillance through emergency assessments. Take a second. Which answer would you pick? The correct answer is A. Passive surveillance through standardized reporting. A is correct because passive surveillance is the regular collection of health data from sources like hospitals and clinics without active engagement in data seeking. Standardized weekly disease reports flowing into a database without provider outreach fits this type exactly. B is wrong because active surveillance involves proactive outreach by health workers to find cases through interviews, exams, or direct clinician contact. The scenario describes routine inbound reporting without outreach, which matches the opposite category in the surveillance framework. C is wrong because sentinel surveillance uses selected reporting sites for trend monitoring rather than universal reportable disease reporting. The scenario describes a broad notifiable disease database covering all hospitals and clinics, which is not the sentinel approach. D is wrong because disaster surveillance involves rapid assessments after specific events, often using methods like Casper door-to-door surveys. The scenario describes routine ongoing collection rather than event-triggered assessments, making disaster surveillance the wrong fit here. Passive surveillance is the quiet backbone of public health monitoring. It relies on routine data flowing in from hospitals, clinics, and laboratories, without public health staff actively seeking out cases. The system draws from reportable disease databases, vital records, and hospital discharge data. State laws require clinicians and labs to notify authorities when specific diseases are diagnosed, covering infections like measles, hepatitis B, and tuberculosis, as well as select chronic conditions. A clinician diagnoses a reportable condition and submits a standardized report electronically. That data flows into a state database, where analysts track trends, spot clusters, and trigger investigation when patterns warrant, all running continuously in the background. Passive surveillance waits for data to arrive, cheap and continuous but incomplete. Active surveillance deploys staff to seek data out, thorough but expensive. The two approaches complement each other, with passive handling routine monitoring and active filling gaps where completeness matters most. When an exam question describes standardized reporting from hospitals and clinics without active outreach, that is passive surveillance, if the data flows in rather than being sought out, passive is your answer. Question 43. A traveler returning from West Africa is asymptomatic but had close contact with the confirmed Ebola case. A different traveler arrives at a hospital with confirmed Ebola symptoms including fever and bleeding. The first must be separated while asymptomatic, the second while symptomatic. Which option matches? Your options are A. Both placed under isolation regardless of symptoms. B. Both placed under quarantine until incubation ends. C. First in isolation, second in quarantine, respectively. D. First in quarantine, second in isolation, respectively. Before I reveal it, which one do you think is right? The correct answer is D. First in quarantine, second in isolation, respectively. D is correct because quarantine separates exposed asymptomatic individuals during their incubation period, while isolation separates confirmed symptomatic cases from healthy people. The asymptomatic traveler fits quarantine, and the symptomatic Ebola patient fits isolation, matching the standard definitions. A is wrong because isolation specifically applies to symptomatic individuals with confirmed disease, not asymptomatic exposed contacts. Placing both travelers in isolation collapses the distinction between exposed but asymptomatic and confirmed symptomatic cases, which the framework keeps strictly separate. B is wrong because quarantine applies only to asymptomatic people who may have been exposed, not to confirmed symptomatic cases. Placing the symptomatic Ebola patient in quarantine misclassifies the situation, since active symptoms trigger a different separation protocol. C is wrong because this option reverses the correct definitions. Isolation is for symptomatic confirmed cases, and quarantine is for exposed asymptomatic people. So placing the asymptomatic traveler in isolation and symptomatic patient in quarantine inverts the framework. Two public health interventions that sound similar but apply to entirely different people. The critical distinction comes down to one thing: symptom status. Isolation applies to people who are confirmed sick or symptomatic, meaning they have the disease and can spread it. Quarantine applies to people who have been exposed but are not yet showing symptoms, during the incubation window when disease might still develop. Think of two travelers arriving during an Ebola outbreak. The asymptomatic contact who touched a confirmed case enters quarantine for 21 days, the full incubation period, monitored daily for fever. The traveler arriving with fever and bleeding enters strict isolation in a negative pressure room with full protective equipment. Both interventions exploit incubation biology. There is a window between exposure and symptom onset when a person harbors the pathogen but feels well. Quarantine captures that hidden window. Isolation captures the period after symptoms appear. Together they cover the full transmission risk across a disease's natural course. Exam questions will reverse these terms as distractors, but the rule holds every time. If the person is symptomatic with confirmed disease, the answer is isolation. If the person is asymptomatic but exposed, the answer is quarantine. Symptom status is the anchor. Question 44. After a Category 3 hurricane strikes a coastal county, public health teams deploy in two-person groups across randomly selected neighborhoods to interview residents about injuries, displacement, water access, and unmet medical needs. They visit households door to door over 3 days. Which assessment method does this represent? Your options are: A. Reportable disease surveillance from hospitals. B. CASPER, a community emergency assessment method. C. Sentinel provider-based outbreak detection. D. Routine vital records data collection. What's your answer? Commit to one before I continue. The correct answer is B. CASPER, a community emergency assessment method. B is correct because CASPER, the Community Assessment for Public Health Emergency Response, uses door-to-door surveys in randomly selected neighborhoods after disasters to assess immediate needs. The scenario fits CASPER exactly with post-hurricane teams, household visits, and need-focused interviews. A is wrong because reportable disease surveillance pulls data from hospitals and clinics, passively rather than from household visits. The scenario describes door-to-door interviews after a disaster rather than disease reporting from clinical sites. The wrong methodological match. C is wrong because Sentinel surveillance uses designated provider sites to monitor disease trends rather than disaster impact assessments. The scenario describes household level needs assessment after a hurricane rather than provider-based reporting, which makes sentinel surveillance an incorrect match. D is wrong because routine vital records collection compiles birth and death data from official registries continuously. The scenario describes an event-triggered rapid household survey rather than ongoing vital statistics collection, which places it in a different methodological category. CASPER, the Community Assessment for Public Health Emergency Response, is the CDC's standardized method for rapidly gathering population-level data immediately after a disaster strikes. During disasters, normal surveillance infrastructure breaks down. Hospitals are overwhelmed, electronic systems may be offline, and displaced populations vanish from routine data streams. CASPER fills that gap by going directly to households in the affected area. The method rests on a two-stage cluster design. 30 geographic clusters are selected proportional to population size, and 7 households are chosen within each cluster. 2-person teams conduct standardized door-to-door interviews, yielding 210 total households, enough to produce statistically valid population estimates. Each household interview covers injuries, illness, displacement, water and food access, and unmet medical needs. Critically, actionable population estimates are ready within 48 to 72 hours, faster than any comparable post-disaster assessment method. On the exam, look for the combination of a disaster setting, random door-to-door household data collection, and a timeline of just a few days. That triad points directly to CASPER every time. Question 45. A state epidemiologist reports that early in a measles outbreak, each infected person was transmitting the virus to roughly 12 to 18 susceptible contacts in an unvaccinated community. This number describes the average secondary cases generated by one primary case in a fully susceptible population. Which concept is this? Your options are A. Attack rate, proportion of exposed infected. B. Case fatality rate, proportion who die. C. R0, basic reproduction number of agent. D. Incidence rate, new cases per population time. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. R0, basic reproduction number of agent. C is correct because R0 is the basic reproduction number of an infectious agent, representing the average people one infected person transmits the disease to in a fully susceptible population. 12 to 18 for measles fits this exactly. A is wrong because attack rate measures the proportion of exposed individuals who develop disease during a specific outbreak period. The scenario describes the average number of secondary cases per primary case, which is a different epidemiologic measure entirely. B is wrong because case fatality rate measures the proportion of infected people who die from the disease. The scenario describes how many secondary cases each primary case generates, which is a transmission measure rather than a mortality measure. D is wrong because incidence rate describes new cases per population per unit time. The scenario describes secondary case generation per primary case rather than population level case counts over time, which makes incidence rate a different metric here. R0, or R sub 0, is the basic reproduction number, a single value that captures how transmissible an infectious agent is in a fully susceptible population. It emerged from early 20th century mathematical modeling and became central to modern epidemiology. When R0 exceeds 1, each case generates more than one new case on average and the outbreak expands. Below 1, cases dwindle. The threshold of 1 is the mathematical boundary separating epidemic growth from epidemic decline. R0 varies dramatically across pathogens. Measles sits at 12 to 18 in unvaccinated populations, making it one of the most transmissible human pathogens. Pandemic flu ranges around 1.5 to 2, while seasonal flu hovers near 1. Airborne transmission consistently drives higher values. R0 directly sets the herd immunity threshold, with measles at R0 12. Roughly 11 of every 12 contacts must be immune, about 92% coverage, to interrupt transmission. Higher R0 demands higher vaccination coverage, which drives the design of immunization programs worldwide. If an exam question asks how many people each case infects in a fully susceptible population, that is R0, keep a few benchmarks in mind. Measles 12 to 18, flu around 1.5, and the herd immunity logic becomes intuitive. Question 46. A public health communicator drafts a flu vaccine campaign and crafts the central, concise statement that captures the main idea, frames every fact sheet, and anchors all media interviews. The statement must be memorable, focused, and consistent across all materials. Which communication element is being described? Your options are A. Key message, the central, concise statement. B. Press release, a short news document. C. Communication package, a collection of related materials. D. Media advisory, an event invitation for reporters. Which would you go with? Lock it in before the reveal. The correct answer is A. Key message, the central concise statement. A is correct because a key message in public health communication is a concise statement that conveys the main idea or purpose of a communication effort. It anchors campaigns, fact sheets, and interviews, fitting the scenario exactly as defined. B is wrong because a press release is a short news document delivered to reporters in plain language to summarize research. The scenario describes a single anchoring statement rather than a multi-page document, so press release fits poorly. C is wrong because a communication package is a collection of related materials designed to achieve a specific objective, like fact sheets, brochures, and social media posts together. The scenario describes one anchoring statement rather than the bundled collection. D is wrong because a media advisory is a short notice inviting reporters to a press conference or event, including time, date, location, and speakers. The scenario describes the central anchoring message rather than an event invitation. In public health communication, every effective campaign is built around a core concept called the key message, a single, concise statement that captures the main idea and guides every piece of communication that follows. A key message is not a slogan or a tagline. It is the disciplined, repeatable statement that every fact sheet, social media post, press release, and interview answer must reflect. Consistency is what gives it power. Think of the key message as the spine of the campaign. Every communication material, from a clinic handout to a tweet, hangs from that one central statement, ensuring audiences encounter the same core idea no matter where they look. Students often confuse the key message with related terms. The communication plan is the strategic document organizing the campaign. The communication package is the full collection of materials. A media advisory invites reporters to events. Each plays a separate role. Only the key message is the central anchoring statement itself. When audiences encounter the same key message repeatedly across multiple channels, it accumulates in memory and drives behavior change. Scattered or inconsistent messaging weakens that effect. Disciplined message control is the foundation of effective health communication practice. Question 47. A public health team preparing a youth vaping prevention campaign assembles a coordinated set of fact sheets, brochures, social media posts, short videos, and press releases. All materials carry consistent messaging and shared branding to support the same campaign objective. Which communication concept does this assembled set represent? Your options are A. Communication plan outlining strategy and approach. B. Key message, the central concise statement. C. Media advisory inviting reporters to events. D. communication package a coordinated material set? Don't overthink it. Which one feels right? The correct answer is D. Communication package, a coordinated material set. D is correct because a communication package is a collection of related materials and messages designed to achieve a specific objective, including fact sheets, brochures, press releases, social media posts, and videos. The assembled coordinated set fits exactly. Is wrong because a communication plan is a strategic document outlining the overall approach and coordination of communication efforts. The scenario describes the actual deliverable materials being assembled rather than the strategic plan, which is a different deliverable. B is wrong because a key message is one concise central statement, not a bundle of materials. The scenario describes multiple coordinated deliverables across formats rather than a single statement, so key message does not capture the assembled set. C is wrong because a media advisory is a short notice inviting reporters to a press conference or event. The scenario describes a campaign-wide bundle of materials with consistent branding rather than an event invitation. The wrong concept here. A communication package is a coordinated bundle of materials, fact sheets, brochures, videos, social media posts, press releases, all designed to support a single campaign objective. What makes it a package is consistent messaging and shared branding across every piece. Each format serves a different audience segment and channel, but every item carries the same core messages and visual identity. The package gives audiences multiple entry points into the same content. Think of the campaign objective as the hub. Every material in the package is a spoke that radiates outward to a different audience segment, while remaining anchored to that shared core. Repetition across channels compounds the campaign's reach and reinforces the message over time. Exam questions often test whether you can distinguish these related terms. A key message is a single statement. A communication plan is the strategic roadmap. A press release is just one item that may sit inside a package. The package itself is the assembled set of coordinated deliverables. Whenever a question describes a coordinated bundle of materials with consistent branding or supporting one campaign goal, that is a communication package. Not the plan, not the message, not any single piece within it. Question 48. A public health teacher explains how a teenager who watches her older sister consistently choose water over soda begins selecting water herself, gradually building belief that she can also make healthier choices. The teacher emphasizes observational learning, modeling, and self-efficacy. Which behavior change theory does this match? Your options are A. Health belief model focused on perceived susceptibility. B. Social cognitive theory focused on observational learning. C. Stages of change focused on readiness. D. Reasoned action focused on intentions. Got a guess? Lock it in. The correct answer is B. Social cognitive theory focused on observational learning. B is correct because social cognitive theory, developed by Albert Bandura in the 1960s, emphasizes observational learning, modeling, reciprocal determinism, and self-efficacy as drivers of behavior change. The teenager learning by watching her sister fits this theory exactly. A is wrong because the health belief model focuses on internal beliefs like perceived susceptibility, severity, benefits, barriers, cues to action, and self-efficacy. The scenario emphasizes observational learning and modeling, fitting a framework focused on social learning. C is wrong because the stages of change model focuses on progression from pre-contemplation through maintenance, organized by readiness rather than social learning. The scenario emphasizes modeling and observational learning rather than where she sits on a readiness continuum. D is wrong because the theory of reasoned action and planned behavior focus on attitudes, subjective norms, and intentions driving behavior. The scenario centers on observational learning from a role model, which fits a different framework emphasizing social processes. Social cognitive theory, developed by Albert Bandura in the 1960s, explains behavior change as the product of three interacting forces: personal factors, environment, and behavior itself. It grew directly from his Bobo doll experiments, which demonstrated that children learn aggressive behavior simply by watching adults model it. Bandura called this interaction reciprocal determinism. No single force drives change alone, emphasis. The person, their behavior, and their environment continuously shape one another in a reinforcing cycle. At the center of the theory are several linked constructs. Observational learning and modeling describe how watching a trusted role model builds the belief, self-efficacy, that you too can perform the behavior. Outcome expectations and self-regulation complete the system, explaining why behavior is sustained over time. This is social cognitive theory in everyday life. The sister never gives a lecture, she simply models the behavior, the teenager's imitation, and her growing confidence that she can make the same healthy choice. Illustrates observational learning and rising self-efficacy working together. When a question describes someone changing behavior by watching others succeed, that is the fingerprint of social cognitive theory. Look for modeling, observational learning, and self-efficacy as your key signals, and distinguish them from internal threat perceptions or readiness stages used by other frameworks. Question 49. A diabetes prevention program targets individual knowledge through patient education, family habits through household coaching, workplace policy on healthy snacks, neighborhood walk-in infrastructure, and state policy on sugary drink labeling. The program intentionally addresses multiple levels of influence. Which framework guides this multi-level intervention strategy? Your options are: A. Health belief model focused on individual perceptions. B. Stages of change focused on readiness. C. Social ecological model addressing multiple influence levels. D. Reasoned action focused on attitudes. Which one is it? Pause the video if you need more time. The correct answer is C. Social ecological model addressing multiple influence levels. C is correct because the social ecological model examines the dynamic interplay among physical, social, and policy environments across individual, interpersonal, institutional, community, and public policy levels. The diabetes program fits this multi-level framework exactly as designed. A is wrong because the health belief model focuses on individual level perceptions and beliefs driving behavior. The scenario explicitly targets multiple levels from individual through family, workplace, neighborhood, and state policy, which exceeds the single-level scope of this model. B is wrong because the stages of change model focuses on individual readiness moving through 5 stages. The scenario targets multiple levels of influence beyond the individual, making the stages of change framework too narrow for this multi-level intervention. D is wrong because the theory of reasoned action focuses on individual attitudes and intentions producing behavior. The scenario targets workplace, neighborhood, and state policy levels alongside the individual, exceeding the individual focused scope of this theory. The social ecological model is a multi-level framework that explains how health behavior is shaped not just by the individual, but by the many nested environments surrounding them. It emerged from Bronfenbrenner's ecological systems theory and was adapted by public health researchers in the 1980s, when single-level interventions kept falling short. The model arranges 5 levels like nested rings. At the center sits the individual, their knowledge, attitudes, and beliefs. Moving outward, interpersonal relationships. Institutions like workplaces and schools, the broader community, And finally, public policy, each add another layer of influence on behavior. Each level captures a distinct set of influences. Behavior is never the product of just one level. It emerges from the interaction of all five simultaneously. A program targeting only individual knowledge often fails because the surrounding environment keeps reinforcing the old behavior. Addressing all five levels creates consistent pressure toward change across every context a person inhabits, each level reinforcing the others. When a question describes an intervention spanning individual education, social networks, institutional policy, community campaigns, and legislation all at once, that's the social ecological model. Tobacco control is the classic real-world example. Counseling, social norms, smoke-free laws, taxes, and community campaigns working together to produce lasting population-level change. Question 50. A public health team launching a maternal health initiative in a refugee community holds listening sessions with mothers, partners with elders to interpret cultural norms, hires bilingual community health workers from the population, and revises program design based on community feedback before rollout. Which principle most clearly drives this approach? Your options are A. Respecting cultural diversity through community engagement. B. Conducting passive surveillance through routine reporting. C. Enforcing mandatory regulations through police power. D. Implementing evidence-based programs without local input. Take a second. Which answer would you pick? The correct answer is A. Respecting cultural diversity through community engagement. A is correct because community engagement ethics center on respecting cultural diversity, working collaboratively with community groups, and adapting interventions to local context. Listening sessions, elder partnerships, bilingual hiring, and feedback-driven design fit this principle as the dominant driver. B is wrong because passive surveillance involves routine collection of health data from hospitals and clinics without engagement in data seeking. The scenario describes deep collaborative program design rather than passive data collection, making surveillance the wrong principle here. C is wrong because police power is the legal authority of government to enact regulations for public health and safety. The scenario describes voluntary collaborative engagement rather than regulatory enforcement, making police power the wrong principle for this rollout. D is wrong because evidence-based public health integrates scientific evidence with practitioner expertise and community values. The scenario explicitly elevates local input and cultural adaptation, so an approach without local input would directly contradict the team's design principles. Community engagement is the practice of working collaboratively with community groups to address health issues affecting their well-being. It's considered both an ethical requirement and a practical necessity for effective public health work, especially with communities that have experienced historical harm or bring distinct cultural perspectives. The modern framework emerged partly in response to failures like the Tuskegee syphilis study, which ran for 40 years without informed consent. Its aftermath forced public health to confront how it had harmed marginalized communities, making genuine partnership, not superficial inclusion, the new standard. The mechanism behind better outcomes runs through 4 compounding pathways. Trust enables honest feedback. Honest feedback produces better fit with local realities. Fit generates community ownership. And ownership drives sustainability long after external funding ends. Each stage reinforces the next. Cultural humility, formalized by Terevelon and Murray Garcia in 1998, captures the practitioner's stance. Workers enter communities as partners rather than outside experts, commit to lifelong learning about the people they serve, and recognize the limits of their own cultural perspective. This shifts the power dynamic from expert and recipient to genuine shared partnership. Community-engaged programs take more time to design, but they fit local realities, earn trust, and persist because the community owns them. When you see language about listening sessions, older partnerships, bilingual community health workers, and feedback-driven design, that's community engagement built on respecting cultural diversity.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.